Good afternoon, distinguished professors, respected doctors, and ladies and gentlemen. On behalf of Hetero Labs Limited Myanmar, it is my great pleasure to warmly welcome you all to today's scientific symposium on One Pill Double Impact. We are honored by your presence and appreciate your valuable time in joining us today. Please allow me to introduce myself. My name is Winsu Mo from Hetero Labs Limited Myanmar, and I am the Master of Ceremony for today's scientific program. We kindly request all the participants to take their seat as the program will begin shortly. Thank you. Now we are going to hold this panel discussion with 10 key agendas. I would like to read out the agenda before we start. Agenda 1. Introduction speech by our country manager, Mr. Babesh. Agenda 2. Official inauguration of Ambassador L by all participants. Agenda 3. Opening speech by Professor Tantan E. Agenda 4. Scientific program 1 on 2 mechanisms, 1 goal. Optimizing glycemic and cardiovascular outcome with Empagliflozin, Linagliptin by Dr. Manash. Agenda 5. Scientific program 2 on translating evidence to practice, overcoming clinical inertia with early single-pill combination in type 2 diabetes mellitus by Professor Koko. Agenda 6. Product presentation by Assistant Product Manager, Ms. Ethan Nawin. And Agenda 7, question and answer session. Agenda 8, closing remark by Professor Tantan E. Agenda 9, lucky draw session. And the last agenda is our country manager, Mr. Babesh, will be giving a vote of thanks in the end. Ladies and gentlemen, before our symposium starts, may I kindly request all the participants to scan the QR code displayed on the screen and answer the preclinical insight clinical survey. May I kindly request to scan this QR code and answer the preclinical insight clinical survey. It only takes 5 questions that will help us a lot to understand your valuable insight on diabetes mellitus. Thank you. Ladies and gentlemen, we shall now begin our scientific symposium. To officially welcome all distinguished guests and participants, may I respectfully invite our country manager from Hetero Labs Limited Myanmar to deliver a welcome address and brief company introduction. Please give a warm applause for our country manager.
Good afternoon and Minglaba everyone. So I formally welcome all of you to this event, which is on the topic One Pill Double Impact and Advancing Diabetes Management. Respected Chairperson, Professor Tantani Madam, Professor Koko Sir and Dr. Manash Baruah Sir. I heartfully thank all of you to join, including all the members, all the doctors, members of Myanmar Medical Association, and definitely my beloved hetero colleagues. So I would like to, I'm very excited and I would like to welcome all of you to today's event. Today we are launching, it is the launch of our new product, Empazox L, which is the fixed dose combination of Empagliflozin and Linagliptin. So Dr. Diabetes management has evolved a very, significantly over the years. And today, type 2 diabetes management is not only about controlling glucose levels, but also addressing the broader patient needs, including cardiovascular, renal, and metabolic needs. So the right therapy at the right time can create a meaningful impact in patient journey. At Hetero, our vision is always been to, give accessible and affordable medicine and some innovative medicines to Myanmar healthcare professional and to the patient community of Myanmar. So that's why we are launching such kind of products. We are now very focused for cardio, renal, and metabolic segments, particularly cardio-diabetic, and we are very focused for to launch new and innovative product at accessible and affordable price to the Myanmar community. So today, with the introduction of Empazox L, we aim to support clinicians with a convenient treatment options, combining established mechanism in type 2 diabetes management, bringing together the benefits of SGLT2 inhibition and DPP4 inhibition. We are truly honored to have such respected expert with us today. Dr. Manash Baruah, sir, who will share his valuable insights on optimizing glycemic and cardiovascular outcome with empagliflozin and linagliptin, whereas Professor Coco, sir, who will guide us on translating clinical evidence into everyday practice and overcoming clinical inertia in type 2 diabetes management. I am confident today that with today's valuable session, everyone, all the doctors, including all the members of Myanmar Diabetes Association, will get some specific insights from these sessions. So thank you once again, all of you. And with this, I would like to have the next agenda of this event. Thank you very much, Vinsu.
Thank you very much, sir, for your inspiring welcome remark. Ladies and gentlemen, now it is the time for official inauguration ceremony of Ambassador L. May I kindly invite all the chairpersons and speakers to join the inauguration ceremonies on the stage. Yes. So, ladies and gentlemen, please join me in congratulating the successful launch of Ambassador L. I will count 1, 2, 3. Yes, step. 5, 4, 3, 2, 1. Thank you. Thank you very much.
So, doctors, thank you very much for attending this event once again. I'm very grateful. Hetero is very grateful that you have attended. With the launch of Empazox L, we are ensuring that we are providing the innovative product at affordable price. And let me tell you, this is the very affordable pricing for your patient. We have launched this fixed dose combination for your diabetes management patient. Important thing is that whatever empagliflozin, linagliptin, this is the very quality product. In fact, API is also Hetero is manufacturing by its own. So there is nothing to outsource, but all the inbuilt capability which Hetero is providing to the doctors, healthcare professionals, and patients. So thank you very much. And we would like to have your support further for this product. Thank you. Please enjoy today's session. Yeah.
Ladies and gentlemen, it is now my privilege to introduce our respected chairperson and faculty members for today's symposium. Our chairperson for today's symposium is Professor Tint, Senior Consultant Endocrinologist, President of Myanmar Diabetes Association and Patron of Myanmar Society of Endocrinology and Metabolism. And Speaker 1, Dr. Manash, Endocrinology and Diabetes Care Specialist from Apollo Excel Care Hospital, India. And Speaker 2, Professor Koko, Senior Consultant Endocrinologist and Advisor of Myanmar Society of Endocrinology and Metabolism. We are deeply honored to have such distinguished experts with us today. To officially commence today's scientific session, may I respectfully invite our Honorable Chairperson, Professor Tint, to deliver the opening remarks and introduce the faculty. Please welcome Professor with a big round of applause.
Good afternoon, distinguished speakers, particularly Dr. Manash from India, and respected colleagues, ladies and gentlemen. It's my great pleasure to welcome you all to today's symposium entitled One Pill, Double Impact. It is my great, over the past decade, we have witnessed a remarkable transformation in diabetes care. Traditionally, our primary focus was glycemic control, with hemoglobin A1C being the principal target of treatment. Today, however, the paradigm has shifted significantly. We now recognize that diabetes is not a merely disorder of blood glucose, but a complex cardiometabolic disease affecting multi-organs, particularly the heart and kidneys. Modern diabetes management, therefore, goes beyond lowering the glucose level. We are increasingly aiming to reduce the cardiovascular event and prevent a heart failure and preserve the kidney function and promote the weight management and improve overall quality of the life. In other words, we are treating the patient as a whole rather than simply treating hyperglycemia. This cardiometabolic approach has led to the emergence of therapeutic agents that provide the benefits extending from beyond the glycemic control. Among these are the DPP-4 inhibitor like Linagliptin and SGLT2 inhibitor like Empagliflozin have become important components of our treatment armamentarium, particularly when individuals to the needs to each patient. Today's symposium and the launch of Linagliptin and Empagliflozin combination reflect this evolution in diabetes care. By combining effective glucose lowering with cardiovascular and renal benefits in a convenient single pill formulation, this therapy represents a direction in which modern diabetes management is moving towards comprehensive, patient-centered, and outcome-driven care. So I'm confident that today's distinguished speakers will provide valuable insight into the scientific rationale, clinical evidence, and practical applications of this combination therapy. So I would like to thank all the participants for joining us today and our sponsors supporting this educational program. With that, I would like to officially open the symposium and invite our first speaker to begin with the sessions. Thank you for their opening remarks. Thank you. So then may I continue to invite our first speaker, Dr. Manash Pratim Baruah. Sorry for mispronunciation. He's going to talk about two mechanisms, one goal, optimizing glycemic and cardiovascular outcomes with Empagliflozin, Linagliptin. Dr. Manash is a promoter, director, head of department, Department of Endocrinology, Apollo Excel Care Hospitals. He is a great person who have achieved so many affiliations and academic achievement, more than 240 publications, original review, editorial abstracts, 3,647 citations, formerly editor-in-chief, Journal of Medical Nutrition and Nutraceutical, associate editor, India Journal of Diabetes, Journal of Endocrinology and Metabolism, and a member Research Guidance Committee, Endocrine Society of India, and reviewer for multiple national international journals, more than 400 scientific communications and faculty, and 27 consensus clinical guidance. And he has so many very impressive the achievement before. And also he has gained so many honors and awards. He's an invited member, Sigma Z, the Scientific Research Honor Society, Great Minds of 21st Century by ABI, American Biographical Society, IJE and Best Original Paper, First Author, 2011, Dr. Biplab Chatterjee Award for Best Published Research Paper in JAMA, Economic Times Inspiring Endocrinologist, Endocrine Academy of Diabetes Award, and Economic Times Ligand Endocrine Award. So we are very lucky to have such a very experienced person, expert. So I would like with that, I would like to invite our honorable speaker, Dr. Manash. Please welcome Dr. Manash.
Thank you. Thank you, Professor Tint, for your nice and long introduction. I don't know whether I deserve all this, appreciations or not. Professor Coco, I mean, we are again here within 24 hours together. All my colleagues, seniors, friends, and young faces, representative of Itaro, thank you very much for bringing me to this nice land. If I start by saying, please correct me if it's wrong, Mingalaba, Diko Yuk Ya Da Wan Tha Bade. It's okay? So half of my job is done. So we're talking about excellent molecules coming together. So before that, I would like to congratulate all the fathers on this Father's Day. And to be fathers, one day you're also going to be the proud father of somebody. At the same time, not to forget the great mothers who are the strong pillars behind that father's success. Without that mother, the father cannot be successful. So power of the father and support of the mother. The power of Empagliflozin and support of Linagliptin. That's what we're going to talk about on this Father's Day. So, I am from Assam, which was a part of Myanmar till 1826, when the Britishers conquered Assam from Burmese king. That is 200 years of history. And interestingly, my city from Yangon may be 1.5 hour flying time, although we don't have direct flight. And my city from Mumbai would be 3 hours flying time. So I'm nearer to you. And this is how it looks from Google. And it's very green, like your country. All the trees, the people, the habits, everything is very similar. I don't feel a foreigner here. I feel very homely here. It's my second time. We are famous for various things. The great river Brahmaputra who flows from Tibet till Bangladesh, going through Assam, and we had various cultures which are originated from Southeast Asia mainly, modified by the people coming from the Gangetic civilization. So we are a mixed population there. And we have a great silk industry. I believe Myanmar also is proud of its own silk industry. So we grow the moths and we create beautiful silk which are very famous everywhere in the world. And we are also the home for one-horned rhinoceros, which is extinct prehistoric animal, but it's preserved in Assam. So you're welcome to visit Assam. Although we don't have direct flight via Calcutta is possible. Please do come to my beautiful state, which I am very much proud of. I'll start with this agenda just to give you a glimpse of what I'm going to take you through. I'll talk about briefly about the burden and the reality, the burden, the healthcare problem in Myanmar in particular, because it's similar to my country and Asian countries. And the evolving landscape, I'll touch upon about type 2 diabetes management. Then I'll come to the core topic of two mechanisms, the pathophysiological synergy of two mechanisms which are being addressed by this fixed dose combination. Then I'll analyze some clinical data and outcomes, of course, that will be taken in details in the practical perspective by Dr. Prof. Koko. Then I'll talk about how this unification will lead us to achieving one goal. And then I'll do some patient profiling, which could be patients alike to what you see in your day-to-day practice. And finally, I will conclude. So the reality, if you talk about a reality in very brief, the reality in Myanmar is high prevalence of diabetes, pre-diabetes, and a growing prevalence. It's not stopping there. And another reality, this is the data from IDF. So this is the number. I don't have to quote it. So you know it's a very huge number. 6.7% could be an understatement. It could be more also. And previous study showed 10%. And most importantly, there is a huge problem of cardiovascular disease, deaths as well as morbidity. And these are the data just to show you. So diabetes on one hand and cardiovascular disease, they go in hand. Both are big enemies. So what is the evolving landscape? If we understand that diabetes is a problem along with cardiovascular disease and of course renal disease, the evolving landscape is a clinical shift. We are now moving from the glucocentric to cardiorenal protection. And the target is to overcome the clinical inertia, just staying on the treatment of sugar. You are moving towards protecting the organs, not only staying on the sugar management. And we want to address multiple pathophysiological defects which lead to the bad outcomes in type 2 diabetes as a whole together from the very beginning, because every passing months, every passing year is a wastage unless you do something early. So this is how it happened actually. Initially, like more than a decade back, we talked about only glucose control and probably not having hypoglycemia, because that was the era when DPP-4 was available and some of the GLP-1s were available. We just wanted to talk about preventing hypoglycemia, not talking about the kidneys and heart because we didn't have the clinical data. Towards the end of the last decade, we started getting the data regarding the cardiorenal protection from SGLT2 inhibitors as well as semaglutide and other GLP-1 receptor analogs. So it was consolidated. Then we talked about patient-centric, that if the patient is in this category, start this. If the patient is in that category, start that. So I will not go into details. So it became patient-centric. Now more specifically, now moving ahead, now the latest guidelines are actually more organ protection specific or centric. That means Now they are directly saying that if you have, they start with, if you have obesity, cardiovascular disease, start with this. They're not talking about HbA1c more than 9, more than 10, do this, do that. HbA1c is important, but first you target the patient's comorbid conditions. Then you talk about what is best to control his hyperglycemia. Earlier it was the different. You were starting with what is best to control this much of HbA1c. Then they talked about protecting the organs. Now we are talking about protecting the organ first, then targeting the different categories of blood sugar with different agents. So that's how it is different. So that is about the changing scenario. And now talking about the changing paradigms of diabetes pathophysiology. So till 2000, last millennium, we talked about 3 mechanisms causing type 2 diabetes. One is insulin resistance, which means there is decreased peripheral utilization of the glucose, especially in the muscle tissues. Then second one is increased hepatic glucose production because of glucagon overactivity. So it's a 2 hormone theory. And third is gradual fall in beta cell secretion of insulin. This is the classical triad of type 2 diabetes mellitus. In 2010, in Banting lecture, Professor DiFronzo first came out with this beautiful idea of ominous octet, where you can see that 8 different mechanisms he has described, and out of which, in today's clinical context, 2 are very important. Decreased incretin effect, which I'm going to discuss right away after a few minutes, and another is increased glucose reabsorption. In type 2 diabetes, the threshold for glucose absorption by the kidneys is shifted towards right. That means if a normal person starts reabsorbing glucose till the cutoff of 180, in type 2 diabetes it becomes 250 or 220. That means they will keep on reabsorbing sugar till the blood sugar crosses 220 or 230 or 240. So the rightward shift causes more hyperglycemia. That's what happens in type 2 diabetes, and that is also addressed by the molecule SGLT2 inhibitor. I'm going to talk about that briefly again. So now talking about the 2 mechanisms. So first I will start with the incretin effect. So this diagram you must have seen so many times. Sorry. Pointer is not. So this diagrams actually shows you what happens when you put a IV dextrose to a person, and what happens the same person or similar group of persons takes oral glucose. Quite contrary to what you'd believe, oral glucose causes secretion of insulin better than IV glucose, and that is called the incretin effect. And that happens because of 2 incretin hormones, GLP-1 and GIP. We know about that. Now, what happens in type 2 diabetes is that there is blunting of that incretin effect. Okay, this incretin effect is blunted. It's something like the IV glucose. Although patient is eating, not much of insulin is secreted. That blunting is overcome by DPP-4 inhibitor. And how does it do it? Sorry. You look at this. So when you take meal, intestinal GLP released, also GIP, and then they are digested by DPP-4 enzyme. So GLP and GIP, they are very fragile hormone. Within minutes of their secretion from the intestinal cells, they are digested. We know that. And DPP-4 inhibitor actually inhibits the DPP-4 enzyme, which digests these peptide hormones, so allow them to work longer and gives the physiological action of insulin secretion. So that is DPP-4 inhibition. There you can see that. And in that DPP-4 inhibition takes care of this blunting of incretin effect in type 2 diabetes. So that's why DPP-4 inhibitors are very popular drug. Remember, DPP-4 inhibitor gives you an incretin effect of the physiological effect. And GLP-1 like semaglutide gives you a pharmacological effect. So DPP-4 doesn't raise the GLP-1 level to a pharmacological level. It only takes care of this blunting and just keep it to the physiological level like normal person. But when you give GLP-1 semaglutide, you are actually injecting huge dose of GLP. It's a super physiological or pharmacological level. So that's why the action on weight is much more. Now talking about the SGLT2 receptor, just look at this cartoon carefully. what happens? In a normal person, 180 gram of glucose load is delivered to the glomerulus every day. If you take all the glomerulus together throughout the day, it's 180 gram. And then this glucose comes to the proximal tubule first. And you see here, SGLT2 inhibitors are there. SGLT2 inhibitors are very primitive molecules, both SGLT2 and 1. They are situated proximal tubule of the kidney as well as gastrointestinal system. They have been developed long back in the evolution to get more glucose, because glucose was scarce in the earlier time in evolution. When animals evolved from the single cell organism, there are not much of glucose. So that's why the body would try to preserve glucose in primitive animals. So that's why it developed long back. And in human, the same mechanism of glucose preservation has gone bad now, because we have plenty of glucose. Throughout the day, we are eating carbohydrate. That's human. But if you look at other animals like lion, he doesn't eat every day. So the plenty of food is actually causing harm to our body. It's a protective physiological mechanism which has overshooted its kind of requirement. That's why we are preserving more glucose. Now, coming back to this, all the glucose coming to the proximal tubule, almost 90-95% will be reabsorbed by SGLT2 and SGLT1. What is the difference between SGLT2 and 1? So SGLT2 is a low intensity but high capacity receptor. So it takes the burden of the bulk of glucose which is coming to the proximal tubule. So it will act fast. So why it is a co-transporter? Because along with glucose, there will be transportation of sodium into from the lumen towards the interstitium, proximal interstitium. And whatever glucose is not acted upon by SGLT2 will be acted upon by SGLT1, which is a very high intensity, specific but low capacity. Low capacity because only 10% is remaining here, right? 90% is getting absorbed here. So whatever 10% remains, again it is taken in by SGLT1. So almost none of the glucose is going there. Now, same thing if you repeat in presence of SGLT2 inhibitor drug, what happens? Sorry. Okay, now same glucose is coming over here. Now you are inhibiting the 90% reabsorption, the high capacity reabsorption of SGLT2 inhibitor here. All the glucose is going out there. You have seen that. When it goes from the proximal tubule to the distal tubule, it will be finally excreted to the collecting duct. So the glucose is lost. And when you lose glucose, your blood sugar comes down and you lose calories. And that's why you lose. It's like you lose calories when you exercise through your sweat. And you lose calories in the SGLT2 inhibition through your urine. So same thing. So you lose weight also. And that's good for type 2 diabetic obesity patients. Now you can ask me why there was no SGLT plus SGLT1 dual inhibitor. Because if you use this mechanism, it is okay for the kidneys, but it is not okay for the gut, because SGLT2 is very much prominent in the gut. If you do not absorb any glucose through the intestine, that is a problem. Moreover, the glucose is going to go into the large intestine and there will be huge diarrhea. That's why the dual inhibitors of SGLT2 and 1 can cause diarrhea, number one. And what is the example? When SGLT2 were developed or known long time back, even in the previous century, the bark of the apple tree, florzen, the derivative of bark of apple tree, florzen, was the original substance from which this concept came. Using those things, scientists saw that it is good for preserving, excreting glucose, but it can cause huge diarrhea. That is because of SGLT1 inhibitor. That's why SGLT1 and 2 combined inhibitors are not popular. SGLT2 inhibitor alone is popular. That's about the science we have seen. Now, coming to the complementary mechanism of action of SGLT2 inhibitor and DPP4 inhibitor, you can see here in almost all the ominous octet, which I'm not going to discuss again. You see red fonts here. Either EMPA or Lina is acting. Almost 6 out of 8 mechanisms of ominous octet are being addressed by these two mechanisms. So that's why the combination becomes a very excellent combination. So now what about analyzing the clinical data and outcome? So let us talk about how in presence of one, the other will act in combination. So let us talk about firstly, Empagliflozin add onto Linagliptin on background metformin. I can show you lots of slides regarding EMPA-Lina combination alone, but mostly in type 2 diabetes, we give metformin in all patients to start with, and it would be a good companion after the metformin add-on. So we should not discard metformin as of now, should not forget about it. But there are similar data, strong data, where EMPA plus Lina given alone without metformin also showed excellent result. Probably Professor Coco will address that part. So my slides are mainly as a top-up of metformin treatment. Okay. Now, this is a change from baseline in HbA1c at week 24 when patient on Linagliptin were given EMPA 25 or EMPA 10. You can see there in the corner, L5 means Lina, E is EMPA. And there was a placebo group also, just for comparison. And this is that you can see 25 milligram, and that one is 10 milligram. Both are similar, almost 0.6% additional reduction in HbA1c, whereas in the placebo group, there is 0.14% increase. That means if you compare to the placebo, it is almost 0.7% reduction. So compared to placebo, 0.7% reduction when you add on to Linagliptin. Next, Linagliptin add on to Empagliflozin on background metformin. It's again very interesting. So now here you have got Empagliflozin 25 group and Empagliflozin 10 group. And here the new drug is Linagliptin because EMPA is already there, and that is compared with placebo. So this is Linagliptin, additional 0.6% reduction. There it is again 0.5, between 0.5 and 0.6 additional reduction. In the placebo, it is 0.1 only and 0.21 only. So there is always an additional extra reduction which is statistically significant if you add Linagliptin to ongoing Empagliflozin therapy. So Linagliptin has a fixed dose, that is 5 mg. So this added benefit is being shown in both these trials. Now moving ahead, what about these are separate pills? These were separate pills. EMPA was there, Lina came, or Lina was there, EMPA came. Now what about combining them together in one pill? So before that, just a precaution. Whenever we talk about fixed dose combination, it sounds pretty friendly for the patient as well as for the doctors. Just write one name, it's done, or the patient just pops up one pill, it's done. But there are certain issues, scientific issues we must need to understand. So number one, the fixed ratio combination products are acceptable only when the dosage of each ingredient meets the requirement of a defined population group, when the combination has a proven advantage over single compounds administered separately in the therapeutic effect, safety or compliance. That means whatever dose is being given individually must be retained in the combination. You cannot play with the dosing just because you want to bring it to a combination. I was giving an example yesterday in Mandala, same example should work here. You have used amoxicillin, all of you. You have used amoxicillin and clavulanic acid. Now, you have, both are given in a particular strength. Now, suppose it is told that if you have to add clavulanic acid to amoxicillin in a fixed pill, you have to bring down the dose of amoxicillin to 125. Will that be acceptable to you? No. You want at least 500 milligram strength or maybe more than that or whatever. At least that much should be there, or 250 for maybe younger children. should be there at least. That is the minimum we require. So you cannot play around with the original dose of amoxicillin when you combine with clobulinic acid. Same thing happens here. Just for the sake of combining into one pill, you cannot play around with the dosing of the prescribed dosing of that particular drug, either empagliflozin or linagliptin, if given separately in that population. So it is 10 at least 10 milligram for empagliflozin and 5 milligram for linagliptin. That cannot be compromised. That is number one. That the minimum necessity for rational FDC is the drugs in the combination should act by different mechanisms. So again, you are not going to combine amoxicillin with ampicillin in a single pill because they are acting in a similar way. You are combining amoxicillin with clobulinic acid because they are acting in different way, but finally giving you an added result. Likewise, you cannot add dapagliflozin to empagliflozin. You're not going to gain anything. That is not rational. You're going to add linagliptin to empagliflozin because although they are working differently, ultimate goal is to reduce blood sugar, and that is the additive goal. So that's what I mean to say here. And then the pharmacokinetics must not be widely different. Now, suppose linagliptin was once daily and empagliflozin was twice daily. That's not a good combination. Again, I'll take you back to one comparison, like you give immediate release metformin and some other combination, long-acting drug. For example, you give linagliptin and immediate release metformin. I don't think that is rational because immediate release metformin has to be given twice or thrice daily because they are short-acting. But linagliptin is given once daily. So what I mean to say that both the drugs should have same trajectory in the pharmacokinetics. If it is once a day, for both of them, it should be once a day. If one is twice a day, one is once a day, it is not a rational combination. That's what I mean to say here. And doses alteration of one drug is not possible without alteration of the other drug. So here again, if you're changing the dose of 5 mg, and now here you have to change it to 5 mg empagliflozin, that is also not rational. So their doses should be ideal when in combination also. And by simple logic, there are increased chances of adverse drug effects and drug interaction compared with both drugs given individually. That means if EMPA is causing X side effect and Lina is causing Y side effect, so in combination, it should not be like a Z kind of side effect. It should be a combination of X and Y. So side effects should not increase just because they are brought into combination, and that doesn't happen with this combination. I'm going to show you some clinical trial data where the side effects of each of them is not going to be increased by combining them together. That's why this combination becomes very ideal. Now, this is a very important slide. It is a PK/PD data, and you'll understand in a few seconds why I have given this. In all FDCs, whenever somebody speaks about FDCs, you should actually look at this data more carefully. This is the data from Boehringer Ingelheim, the innovator of combination of EMPA and Lina original preparation. So you can see here, when empagliflozin is given alone or in combination, or linagliptin is given alone or in combination, the trajectories of them are similar. That means in combination, EMPA will behave the same way as it would if it is given alone, and Lina is also doing the same thing. So we are convinced about this data, and we have used this combination for almost 12 years now in India and many other countries. So it is very convincing about the combinations effects, glycemic, anti-hyperglycemic effects. So if this is the gold standard, what does hetero has? Because I asked for their pharmacokinetic data, and that's very important to discuss that. So I have included this slide. Now, here, hetero groups, their scientists have actually compared the FDC data of hetero product and FDC data of the innovator, that is Boehringer Ingelheim. And what they have done the analysis, concentration analysis over time in fasting as well as fed state. In the fasting state, the innovator, you can see in the bottom, the red one is innovator empagliflozin and the blue one is hetero-empagliflozin, both EMPA as well as LINA were similar. That means their trajectories are just similar as innovator in fasting as well as the fed state. That means now from that data, you can now extrapolate that hetero product also is going to give you consistency if given as fixed dose combination. So that is very convincing. And for me, whenever I write a fixed dose combination, I always first look at this PK/PD data, because efficacy data they are going to bring anyway. But PK/PD data is not shown by many companies. It is very challenging for them, but you always ask for that. And I was very much convinced with their authenticity of their product, because this PK/PD data has been compared to the gold standard, and that is very reassuring. Now moving ahead, what are the clinical trial evidence? Again, fixed dose combinations therapy. I will talk about, again, as I said, added onto metformin, not all the products or all the study trials. So what I'm going to concentrate on is EMPA, LINA, FDC on metformin background. That is the most common scenario. So this is very interesting. You can see here on metformin background alone, LINA could bring it down 0.7, which is just like what I have discussed earlier. That is the capability of DPP4 inhibitor and SGLT. Alone, they can bring down about 0.6 to 0.8. Average is 0.7. You cannot expect more than that. You cannot expect more than 1 if you are using alone. EMPA 10, 0.6, EMPA 25, 0.62. But when you combine them together, it becomes more than 1. And that is fantastic, because anything more than 1% reduction is always fabulous for any oral drug. But you might be asking, these figures are not huge. They are 0.6, 0.7, or maybe slightly above 1. Then you have to look at what you started with. You started with a very low baseline HbA1c. Remember, a person coming to you for the first time, diagnosed to be having diabetes yesterday, he came to you and he said that I'm not going to take anything. His HbA1c is 9.5%. He's refused to take anything. You just advise him diet and exercise. In 3 months, his HbA1c could be 7 or 7.5. So when you start with a very high HbA1c at the baseline, the reduction is also, the quantum of reduction is also very high. But when you start with a very low HbA1c, like this, just around 7, to reduce even just above 1 is fabulous, because in this patient, you are almost reaching the 6.5 or 6.6 target, below 1, below 7%. And you want to patient to be below 7%. Secondly, if possible, in some patients who are healthy, you may be trying to target 6.5%, which you can achieve with this combination. So with a low baseline HbA1c, reducing up to 1% with this fixed dose combination, I would say it's full marks to the combination. Now, the sustenance. Now, it's not only about reducing the HbA1c, the mean value of HbA1c, but also maintaining that reduction for a fairly long period. The same study, this is from Drifonjo study, which showed that individually you did achieve the target well. It remained above 7%, but when you combine EMPA 25 with LINA 5 or EMPA 10 with LINA 5, both the groups finally within 12 weeks time could achieve the target and maintained it till 52nd week, at the end of the study period. So this sustained reduction is also very important. You are not treating your patient for a few weeks, you are treating your patient for months and years. So that sustained result can be achieved by combining these two. So that is another good point of this fixed dose combination. And finally, another important point is, you are treating all your patients, so all your patients should be happy. What if 70% achieve great goals, had great achievements in their goals, and 30% fail miserably? You're still a bad doctor for 30% of your patients. So you are looking at the maximum number of patients, whether they are achieving the target or not. So that's what is being shown here. Only almost 1/3 of our patients are in the target if you are using these drugs alone. But when you're combining them in fixed dose, you are bringing it up to 2/3. That means 2/3 of your patients will be achieving the target, and not in a distant time, within 12 weeks, 13 weeks time. The next possible visit is 3 months, mostly in your clinic. By that time, 2/3 of our patients should be achieving their target. You can see here, 61%, almost 60%. It's more than 60% is 25.5. It's almost 60% at 10. So that is another very strong point in favor of combining these two into a single pill. So change in HbA1c at week 24 with baseline HbA1c more than 8.5. Previously, I have shown you data at the very low HbA1c. I told you the 1% reduction from a 8% reduction is good. But what if your patient had more than 8.5% baseline HbA1c? Here again, the reduction is much more, 1.8. So for an example, if your patient's baseline was more than 9.5 or 10, probably this, in some patients, this should go up to 2% also. So higher the baseline HbA1c, more is the achievement, and that trajectory is maintained by this group of drug, given as fixed dose. So these are very convincing data. So now talking about the cardiorenal and end organ protection very briefly. I'll first cite the EMPA-REG trial. You cannot live without discussing EMPA-REG trial. I know Dr. Coco is also going to discuss about it. This is a very classical trial. I love this trial so much. And in 2015, around this time, September, it came out in Stockholm in the EASD. And the most important part of this trial is that for the first time in the history of diabetes science of diabetes, oral anti-diabetic tablet showed all-cause mortality. And why it is important? You can always debate about heart failure detection. You can always debate about albuminuria detection. You can always debate about the MI detection or stroke detection. There could be some fault in detection on part of some investigator. But there is no doubt about the mortality. If a patient has died, he has died. So it's called that mortality is the hardest evidence either in favor or against any molecule. Now, if any molecule shows all-cause mortality, bottom line, 32%, very significant p-value, it's an excellent drug. It has to be. And look at this, the numbers needed to treat. You need to treat only 39 patients for 3 years to prevent one mortality. Is not that great? This is actually something like statin, which is the star of cardiovascular science. Maybe better than statin, because if you look at the statin data, even 30, it's more than 40 actually to start with. But anyway, not only all-cause mortality, if you look at starting from 3-point MACE, that is cardiovascular death, stroke or non-fatal MI together, is again 14% reduction. NNT, that is number needed to treat, is 63 patients to prevent one event in 3 years' time. Cardiovascular mortality, significant reduction. Hospitalization for heart failure, significant reduction. Hospitalization for heart failure and CV mortality, including atherosclerotic vascular disease like MI and all, there is significant reduction. Incident of worsening nephropathy and more than 40% sustained decline in eGFR. In both this, prevention of both this, there is benefit. So many benefits, all are statistically so very significant. You cannot ignore the importance of empagliflozin. Now, what about linagliptin? Now, you don't expect such great results from DP4 inhibitors. Their mechanism of action is different. They are like kind of a physiological drug, Now, in the Carbonina trial, primary outcome was 3-point MACE like EMPA-REG trial. There was no significant increase in that. It was neutral. That means it was not harmful, but not with any added benefit. The secondary composite kidney outcome, again, it was neutral. It didn't decrease the kidney events significantly, but it was not harmful. So this is like one analogy which I cited yesterday. Dr. Coco liked it. If you compare empagliflozin like a king, a kind, gentle, yet dominant, forceful king, who is liked by all his subjects. Linagliptin works like a gentle, charming queen. And without the presence of queen, the king cannot perform. The king has to have his mind in peace, domestic or other support-wise. Queen is the greatest support for the king, right? Likewise, Empa, the king, is being supported so nicely by Lina, the queen. So that becomes a very good combination. And if you add every king has got one able prime minister to support him. So metformin is your prime minister. He's already there. So combining them will not harm your kidneys and heart if Lina is there. And there is more data for Linagliptin. I'm going to show it. So before that, the separation of graft for heart failure with empagliflozin happens very early. And in Carbonella trial, there was no increased incidence of heart failure or hospitalization of heart failure with linagliptin. So linagliptin was found to be very safe from the heart failure point of view. Why it is important? Last decade we had one study coming out, which was called Savor-Timi trial. It used saxagliptin, another popular DP4 inhibitor of that time. It found that there is increased hospitalization due to heart failure. And people started blaming DPP4 class as a whole, saying that this is bad for the heart. Actually, Carmelina trial and TICOS trial with sitagliptin that refuted that notion that DPP4 inhibitors are harmful. They are not helpful in heart failure, but they are not, at least sitagliptin and linagliptin are found to be not helpful, but neutral in heart failure. So neutral queen with able king, again for heart failure. Now, again, prevention of worsening of nephropathy, excellent result with empagliflozin, ably supported without any new harm by linagliptin. And from various angles, if you compare, like end-stage kidney disease or death from CV cause, or end-stage kidney disease or death from any other cause, CV cause and any other cause, in all of them, in EMPA trials, it has been shown that there is significant benefit with SGLT2 inhibitors as empagliflozin. So there is no doubt about the fact that it's a very strong protector of the heart and the kidneys. Now, this is very important, and that I am coming back to linagliptin. Although linagliptin didn't have any data showing that it is extra protective to the heart and the kidneys, if you have to combine any DP4 inhibitor with any SGLT2 inhibitor, it has to be linagliptin. Why? You don't have to reduce the dose of linagliptin in any stage of kidney failure. For vildagliptin, for sitagliptin, you have to come up to even 1/5 of the dose when the kidney failure reaches, say, stage 4 or 5. But linagliptin, you just give it and close your eyes. It's a very safe drug. And same with liver. A chronic liver disease, one drug can be given blindly, that is linagliptin. For other drugs, you have to be careful. Linagliptin and saxagliptin are safe for liver. Others are not supposed to be safe at the advanced stages. Child C phase of cirrhosis cannot be given. But you can give saxagliptin and linagliptin even in child C cirrhosis. But we don't use saxagliptin for various other reasons. What you are having? Only linagliptin. Now, this is very interesting. See, in mild renal insufficiency, you have got 0.7% reduction. Is something like what you have seen in the clinical trial. What is the expectation? 0.7%. But if you use it in more severe renal insufficiency, the efficacy increases. That's very interesting. From mild to severe end stage, you reach 1%. Only linagliptin has got this kind of data amongst the orals. You cannot use SGLT2 inhibitors in the stage 5 CKD because at 20% you should stop it because there is no benefit. But linagliptin can still be given, although there is no harm in stage 4, 5, but you don't have to use it newly. So linagliptin has the data up till renal transplant, 1%. So that's why I would choose, if there is even an a slightest indication of kidney disease, I will start with linagliptin from that day 1 onwards, and I'll close my eyes because this can go on forever till the patient has renal transplant, if at all he has to or she has to. So safe for the kidneys, linagliptin, choose it. Now, this is a very interesting data from India. It shows the benefit in liver disease. It used linagliptin, empagliflozin, and they did MRI analysis of the liver fat. And what they saw, compared to the placebo group here, where there was insignificant reduction, here there is very significant reduction in the empagliflozin group. So your liver fat, inflammation, and fibrosis can be decreased with linagliptin, but this is indirect evidence from MRI. There is no biopsy proven data. So I'm not saying that you should use it always in MAFL here. You have to use GLP-1 receptor analog. For that, we have got ample data from semaglutide, but these are not harmful, may be helpful. Okay. Next, this is an universal phenomenon. I think all of you who have used this drug in patients with transaminitis, where your liver enzyme elevation is common, you can see that there will be reduced AST level. And whenever AST level is decreased, that means that the liver injury, the fat-related inflammation is actually going down. It's an indirect evidence. So it is helpful for the liver also. So what about a patient profile? So I will start with the safety profile analysis. This is a pooled data analysis. It shows that the non-specific adverse events which is related to any other drug are not significantly increased in this combination or fixed dose combination compared to each of the drug alone. So that is very reassuring. And you are more interested in three things: hypoglycemia, urinary tract infection, and GTI, genital tract infection. So hypoglycemic events are not increased in combination. You can see compared to each drug alone, the combination doesn't increase hypoglycemia. That is very reassuring. Numerically lower incidence of genital infection. That is very interesting again. You expected no change in genital infection because it's caused by empagliflozin, not linagliptin. But when you combine linagliptin with empagliflozin, your GTI incidence decreases. And there is a scientific explanation to it. Before that, comparable incidence of urinary tract infection. So contrary to what people believe, clinical trials have never shown increased incidence of urinary tract infection because the pre-selection is very important. In all clinical trials, investigators, they put a lot of thoughts into recruiting a patient. Same thing you should do. You're not going to give this patient to a patient with a history of pyelonephritis. You're not going to give it to a patient who has a history of recurrent UTI within 6 months. You're not going to give it to a patient with benign prostate or grade 3 benign prostatic hyperplasia causing bladder obstruction because he is a vulnerable case. You're not going to give it to a patient who may have structural defects in the urinary tract causing infection, which is vulnerable, making the patient vulnerable. So all these points considered, rest of the patients, they're not at more risk for UTI. No clinical trial, even EMPA-REC trial also didn't show any increase in UTI because the pre-selection was very carefully done. Now coming back to the GTI, this is very interesting that this data has got Defonzo's paper also. It's a meta-analysis showing that when you combine SGLT2 with DP4 compared to SGLT2 used alone, the incidence of GTI comes down. This is an universal truth. That's why the meta-analysis proves it. And why it is so? It is said that the inhibition of DPP4 enzyme present in some bacteria or fungi may lead to less infections. Very interesting. If you want to discuss it further, we can take it up once again during this discussion. So that's to cut it short. So move ahead. I'm just showing it. So this has been proven by clinical trials. You may experience the same thing in your practice also. Now this is very important. This is not very common, and it is almost a forgotten topic when you discuss about the A1C reduction and cardiovascular. So that's why 1-2 slides, I think it's very important. Very rare, but very potentially dangerous. Very important for you to understand. What is euglycemic DKA and why SGLT2 inhibitors cause it? So firstly, SGLT2 inhibitors act independently of insulin to excrete excess glucose in urine, and this creates several metabolic shifts. What are those shifts? One, there is decreased insulin and increased glucagon. So when you kick out the sugar, body tries to rebuild the sugar pool by breaking down the liver glycogen. And what does it do? It produces more glucagon to protect the body from hypoglycemia. That's a reverse physiological mechanism which happens all the time in your SGLT2 inhibitor patients. Now, and that same thing will lead to lipolysis and little amount of ketone production. In your SGLT2 inhibitor patients, you might encounter ketonuria in the morning sample. So 1 trace to 1 plus ketonuria is not dangerous. You can just forget about it. That's a natural mechanism because there is an amount of ketone production in the body from the fat source when you use SGLT2 inhibitors. But 2, 3, 4 ketonuria is dangerous because that could be an indicator of EDKA, and it happens without hyperglycemia. Unlike diabetic ketoacidosis, which can only happen your blood sugar is more than 250 or 300. This actually happens below 250. So blood sugar is not going to be the indicator. Mask hyperglycemia, because you're throwing out the glucose all the time, the hyperglycemia is masked. It doesn't represent what is happening in the metabolic mechanism or metabolic background of the body. So that's why it becomes undetectable and dangerous unless you have you take an extra care to detect it. Now, the common triggers are like fasting or ketogenic diet. Nowadays, ketogenic diet is very popular among some people. So they go on fasting for long periods and many days, producing lot of ketones that might merge with your euglycemic decay. That is one. Acute illness, infection, sepsis. You have to stop this drug in those conditions. All hospitalized patients, I stop it. Irrespective of the condition, in hospitalized patient, I don't take the risk of giving it. And don't start it in hospitalized patient. You will not be legally safe in future if the patient dies of any other cause. So, excessive alcohol intake. Be careful in those group of people who drink a lot of alcohol because alcohol can produce ketones, euglycemic, even hypoglycemic decay. Alcoholic patient after binge alcohol drinking comes to you with unconsciousness, wernicke's encephalopathy. Along with that, they have metabolic derangement. What is that? They will have ketones in urine and they will have hypoglycemia. This combination we do see in alcoholic patients, right? So excessive alcohol intake should avoid it. Dehydration we should avoid it. Of course, in pregnancy you will never give it. So these are the conditions where ketone production may be aggravated. Now, warning signs are nausea and vomiting like ketoacidosis, abdominal pain, rapid breathing like Kussmaul's breathing, and unusual fatigue and confusion. This fourth point is important. Unusual fatigue and confusion, that is the most common symptoms they will come with. So you be careful about the fourth one because rest of them are just like DKA. They will be coming to emergencies with those symptoms, but for your clinic also, this fourth one is very important. Try to look at the ketone excretion in your urine. More than 2, 3, you should be careful, stop it, and again reorganize your treatment. Now, how do we manage? Immediate discontinuation of SGLT2 inhibitor. That's very important. Aggressive intravenous IV fluid hydration. So before insulin, think about hydration. Before insulin. Finally, IV insulin infusion combined with dextrose. What you do in DKA? Normal saline. In DKA treatment, you give IV insulin with normal saline because your blood sugar is always above 250 or 300. Only when your blood sugar touches 250, you switch to dextrose. Here, the presentation itself is happening below 250. So, you begin with a treatment with dextrose or dextrose saline, not normal saline. Remember that is a fundamental difference in your approach to euglycemic decay from normal decay. So next is profiling. So firstly, a patient, 49 years, sedentary type 2 diabetic patient, 5 years, obese, BMI 31, on linagliptin and metformin. Now eGFR is 76, kind of okay. no retinopathy, but patient is a smoker with a family history of CAD. So it's a higher risk in that category. Blood sugar is not controlled with 8.6 A1C. Patient is unwilling for injectable. Most of our patients are unwilling for injectable to start with. What is your third choice? What are the issues you want to address here? The potency of the drug, because you have to bring down from 8.6 to 7. So it should be sufficiently potent. You have to look at the cardiac safety of the drug because the patient has a higher cardiovascular risk. You have to look at a weight gain because you cannot give drugs which can cause weight gain. Patients already 31 BMI. Mechanistically, you have the choices like pioglitazone, sulfonylurea, empagliflozin. But which one you are going to choose? We will come back to answer this after some time. Next question is a housewife, 52-year-old post-menopausal type 2 patients, 12 years. So patient has hypertension, as I said, he's on telmisartan. BMI is kind of borderline. eGFR is 50, already declining. Patient has got macroproteinuria, she is a renal case now. Mild edema, and interestingly, there is evidence of heart failure with preserved ejection fraction. So there is edema and right ventricular strain, which is a marker of heart failure with preserved ejection fraction. Patient had history of hypoglycemia with earlier use of first generation SUs. So patient doesn't have any frank history of CAD. A1C 7.9. What is your third choice? So A1C is not so bad. Here the point is, 1, prevent hypoglycemia. 2, use drugs which are renally safe. And third, use drugs which can prevent the progression of cardiovascular, heart failure. Here I am not putting hyperglycemia as an issue because patient A1C is 7.9. Your switching is for the safety from these angles. So you have the choices, pio, SU, empagliflozin again. If you have to use SU, it has to be second generation because first generation already causing. So it's kind of glycoside sustained release kind of thing. But which one you're going to choose? Again, I will try to come back later. Third one is a driver of public transport vehicle. So driver of public transport vehicle cannot have hypoglycemia. That will lead to accident, causing death of the entire busload of people. So these are the people who are to be given. There is nice guideline. You must avoid drugs causing hypoglycemia to these patients. On metformin, 1,500, but the patient has got GI issues. Could be because of metformin. eGFR is fantastic. Blood sugar is not controlled. One time, one pill. For compliance, you have to use that only because otherwise he will not take if you give 2-3 pills. But wants to avoid weight gain also. What is your switching choice? So what are the issues here? For occupational issues, you have to avoid hypoglycemia. For compliance issues, you have to use one single pill. And for glucose control issues, you have to use one FDC, which has the potential of bringing down the A1C from 8.1 to. What is your target for this patient? 7 or 6.5? Sir, is it 6.5 for him? I think 6.5 is a good target because he is healthy person without nephropathy or any cardiac disease. I will target 6.5 if possible. So is there any FDC which is safe at the same time having the potency of bringing it down by 1.6%, 1.5%? You have to use that. So with this in mind, we are going to search the answer. But before that, very interesting and important slide. This is the ADA guideline which talks about patient-centric approach. What you do basically, if you have the atherosclerotic vascular predominance, then you have to use GLP-1 or SGLT2 with proven CVD benefit. Only one drug has got proven CVD benefit from clinical trial, Empareg, that is empagliflozin. Dapagliflozin doesn't have that. Canagliflozin have got inferior data. Most superior data comes with empagliflozin because of Empareg trial. But remember, that happened because Empareg trial included all CVD patients. 99% patients were CVD patients. They are established cardiovascular disease. So, in the established cardiovascular disease predominance, empagliflozin can be chosen, or a GLP-1 receptor with proven CVD benefit like semaglutide, liraglutide. Now, if there is heart failure or CKD predominance, SGLT2, because No doubt about it. And there is no preference here because all SGLT2 inhibitors are similar for heart failure and nephropathy. This is a class effect. So this is SGLT2. Compelling need to minimize hypoglycemia. Nothing comes before DP4 inhibitor, but their potency is questionable and other benefits are questionable. But still there, DP4, GLP-1, SGLT2 and thiazolidine, pioglitazone. But you have to look at other benefits and side effects also. But SGLT2 is here also. And as a first line, and the second line, you can see this for your second line. So each of them can be second line here for each of the drug. In each vertical, the rest of them, for this vertical, the rest of the drugs can be second line if your A1C is not controlled, right? Here, your A1C is not the first thing you're discussing. You're discussing the comorbid condition, the situation where the patient is in, and what to start with. Finally, compelling need to minimize weight, only two drugs, SGLT2 inhibitor and GLP-1. Of course, GLP-1 are much more potent, but SGLT2 inhibitor 2.5 kilo body weight reduction and sustained reduction is good one. Finally, cost is a major issue, which is very relative thing nowadays. Costs are coming down. So I think we should discard this because the rest of the drugs are getting cheaper and affordable. So previous points are very important in choosing. So now coming back to your patients again, the first case, young man, I mean executive kind of patient, doctor or executive or engineer, had linagliptin and metformin adequate doses, still not control. Of course, if you consider these few points, it has to be empagliflozin and nothing else. I think there is no doubt about that. So next one was a lady who is a CKD patient actually, eGFR standing at 50. It is stage 2. And here the choices were not hyperglycemia. We're avoiding hypoglycemia, renal safety, and secondary prevention of heart failure. Nothing's come even close to empagliflozin. All are distant second. Even pioglitazone is not the choice because it can aggravate heart failure. Sulfonylurea, probably neutrals, the second generations are neutral for heart failure, but they can cause hypoglycemia. So unless there is UTI, I have to use empagliflozin. It is ethical, moral, and practical. Choose empagliflozin. Third one, the driver. Here the hypoglycemia was an issue. Okay, pio versus empa. You can say the pio also can be given. But he said, I don't want to gain weight, pio out. So you help him reduce weight, empa in. SU, of course, cannot be given, although it is very popular drugs everywhere. Cannot be given, hypoglycemia, some weight gain. So, very simple solution. Empa plus linagliptin would be your choice. So, in all these situations, your first thing should come to your mind is this FDC of empa-lina. So, final slide, just to tell you, empa and lina FDCs, fixed dose combination, offers higher efficacy, that is better HbA1c reduction, enabling more subjects, more patients to reach your glycemic goal with convenience of a single pill and an early and more sustainable achievement of glycemic goal. So you start very early, 12 weeks. You sustain it for 1 year, 2 years, 3 years. So that is very important. Combination of offers extra glycemic benefit like weight and blood pressure reduction. Well, didn't discuss about a blood pressure reduction. Dr. Coco is going to address it probably. So 4 millimeter systolic, 2 millimeter diastolic, you can expect. In fact, I had to stop antihypertension in some of my drugs when I started SGLT2. So when you start it, be careful. Tell the patient, measure your blood pressure for few days carefully. Because of diuresis, pressure might come down. And because of other long-term vascular effect, it may come down in a sustained manner also. Empagliflozin proactively provides cardiorenal protection and cardiovascular death reduction. I have shown the EMPA-REG trial, aptly supported by a neutral linagliptin, the potent, gentle, powerful king supported by charming, understanding queen. Absence of any additional safety concerns, I have shown. Use alone or use in combination, no additional safety concern. Or drug interactions. An AMPA-LINA combination can potentially lower GTI, which is of course a concern when you use empagliflozin alone. When you combine, it can potentially lower GTI compared to SGLT2 alone. So this is what I had to tell you today. This is my hospital. See the greenery is just like Myanmar. It's all around. Same tropical trees. So same greenery we have. Thank you so much.
Thank you very much, Dr. Manash, for your insightful and informative presentation. Now we move to our second scientific symposium entitled Translating Evidence to Practice, Overcoming Clinical Inertia with Early Single Pill Combination in Type 2 Diabetes Mellitus. May I respectfully invite Professor Kuko to deliver his presentation. So please welcome Professor Kuko with a round of applause.
Saru Samar Alumingla, and Dini Poeti Miaja, General Poeti Layout, Deputy General, two General Chief Shiva. She now speaker, it's being elaborated very beautifully about all the Empire Lina Bono. So generally, the Empire Lina, General Pio, he said, not home, and after Tung Long, maybe through a live to a Pio Laja. So General the Kuli General. ပြကျင်တာဗောနော်ပြကျင်အဲ့တော့ကျွန်တော်ဒီ slide ကိုခဏခဏပြပါတယ်ဒါကျွန်တော်တို့ကြိုက်လုံးပါဆရာတို့2026မှာဆရာတို့ကုရင်ဒီ design တိုင်းကုဖို့ကျွန်တော်တို့က request လုပ်ထားပါတယ်တစ်ကဆရာတို့ဒီ number ကိုကျွန်တော်တို့ကုရမှာဖြစ်ပါတယ်နော်ဆရာတို့ညနေကျရင်စီကန်းထိုင်ရင်ဆရာ A1C ကို9အောက်ကိုဆရာချโอเค blood pressure က130/80ဖြစ်သွားပြီဆရာကျွန်တော်တို့140/90မဟုတ်တော့ဘူးเนาะ130/80ဖြစ်သွားပြီဆိုတော့ every diabetes patient တိုင်းမှာကျွန်တော်130/80အောင်ရတဲ့နည်းချပါကြိုက်တဲ့စိတ်သုံးကြိုက်တဲ့စိတ်သုံးအကြိုက်ဆုံးကတော့ ACI ARB ပေါ့เนาะကျွန်တော်တို့ကြိုက်နေတော့ဘာလို့အခုနောက်ပိုင်းမှာဘာတွေစကားပြောလာလဲဆို organ protection ပဲဆရာကျွန်တော်တို့ဟုတ်တယ်လေကျွန်တော်တို့ကုနေတာကြီးအကုန်လုံးကဆရာခုနပြောတဲ့ stroke မဖြစ်အောင် heart failure မဖြစ်အောင်အကုန်လုံးဖြစ်တော့ organ protection အရင်စကားပြောလာတယ်ဒါကြောင့်မို့ကျွန်တော်က blood pressure tablet မှာဆရာတို့ ABCD အကုန်ရှိပြီမဲ့လေ the first choice ကဘာတွေဖြစ်လာလဲ ACI ARB ဖြစ်လာတယ် same thing မဲ့ကျွန်တော်တို့ကဒီ diabetes ကိုကုရင်လေ organ protection စီကထိပ်ဆုံးရောက်လာတယ်ဒါကြောင့်မို့တို့က SGLT2 နဲ့ GLP-1 agonist လို့ခေါ်တဲ့ SAMA နဲ့နော်တစီတွေကထိတ်ဆုံးရောက်လာထိတ်ဆုံးရောက်ဒါကိုတို့ကအရင် stress လုပ်နေ2026မှာဆရာတို့ကုရင်တစ်စီးကြကြောင်ကုရမယ်နှစ် organ protection ဆေးကိုသုံးရမယ် blood pressure ကုရင်တစ် blood pressure ကြောင်လုပ်ရမယ် organ protection ဆေးကိုသုံးရမယ် that's the concept ဖြစ်သွားပြီဆရာဒါကြောင့်မို့ဆရာတို့ဒီနေ့ကုတယ်မှာငါအဲ့လိုတိုင်းတွားနေရလားဆိုတော့ကျွန်တော်ပြောချင်ပါတယ်there is a no severe risk ရှိလို့ရှိရင် blood pressure 120/80ကျွန်တော်ကချခိုင်းတယ်သူတို့များ if well tolerated ဖြစ်ပေါ့နော်ဆရာ LDL ကြည့် LDL 55 တိဖြုတ်ချခိုင်းတာဒါ55 တိဖြုတ်ချတယ်ဖြုတ်နိုင်လို့ရှိရင်တဲ့လက်ရှိ level 50% ဖြုတ်ချလိုက်ပါတယ်ဒါတချို့က55တိကို we cannot go down to 55 in number we can reduce up to 50% ဒီချဖို့အတွက် high intensity တုံးမှာ triglyceride ကိုလည်းတို့သုံးခိုင်းပါတယ်ချခိုင်းပါတယ် every case ကို BMI ကိုကျွန်တော်ချခိုင်းတယ်ဒါကြောင့်5 to 10% ရအောင်ချပါဦးเนาะ the same thing ကျွန်တော်က numbers matter but people matter more တဲ့တို့ကလူကိုပိုကြည့်ခိုင်းတယ်လူကိုပိုကြည့်ပြီးတော့ကျွန်တော်ကုတဲ့အခါမှာ age ကိုကြည့်ပါ affordability not that nine la chiba, validity of the drug, side effect, duration of diabetes, educational level, comorbid family support. That's how the personalized management go to agenda. How to every chiba. By that way, also she a target achieve the target. So target young. Number individualized care. Duty of Jintiao, chief your and then improve the organ. By the way, you can better live together. So this slide the chat in any. I'm not general look out, losing data, I can tell I be AI look Canada, AI go Alutwala, general look down to Alu AI, general losing data, I look like Alutwala. So the Ali at the chat in any to P. No? So general dinner therapeutic in Nashavo. And you are failing to initiate or in the spine therapy when health goals are not met, despite clear definition of priority target. Do not I could not build a number in Miao Cha. Luna pressure 160-80. Do not say the outline. Say they are behind. They are touch charging it. Touch page in it. Luna go expel say show la. Anything else, they are not there. Do not let me go to the game and me house. Therapeutic in a chapter. The same thing are a once the Asiati go in it. I mean, Luna, you know, see insulin to Kainoma. Insulin to Kainoma, a joke in you know, the don't allow some Jumbo. Don't allow you, not don't Mama, may I not home and all. I don't sound like daddy. He is being exposure to chronic hyperglycemia. Don't exposure look like a do. I don't like to choke up your time alone. Era Siamata when she, the Jambo Siarodi, Pimientan and Biom, the Unamachino Matana Muse, the Army General look at Bioma go look in, Lao therapeutic in Nasha look over. Tika target is out in it, the target you Chala and common and the Sailor she, Kailine le she, Siaga Maluda, Era therapeutic in Nasha look over, Down Malusi Jamau, Babuleso, General, the target is out the Lalu. The United States Malutara, no, 50% are meow, he wants you. 47% meow. No, libile meow. I don't know Paunale, 22 years, United States, but my mamma who might be woman. General, the Jamro General, Togaria General, a Miaishi, or not in my medication, yeah, era, Miaishi, Parijam Piatanapin, the Telchini Malesine, patient, a teacher, patient, General, baby, Casioga, serious, Mapipa, Ulu, Usare, General Bagale, Paleto, serious, ZGA. No, General complex of Regina, show twin, I say that Miaito, Tibetan see now. I know, the management go, General Kuda Kama, General A1 you say, 6157 out young Chava. Machai, say A1 you say, like 7 out Machai, 20% risky mortality. The yellow 8 solution, 29% microvascular FMCP, 32% mortality chart. The Jamlu General Palesi, General therapeutic in Ashama Piao Locaina. Kulai looking, Town Walim, Sapijare. I have evidence it goes Shivida. I don't clean it in Ashama. Tajam Pitale, Feta don't wish it. And a physician feta, patient feta, no, and then assistant feta. And the other one, a physician, as a 50% as a Rujam. To a Luna, the Kago machine piano, Lunaga, Matiu, the Jamlu, General, to a beneficial Mayara pit. You know, physician in Ashaga, a solo pin, and I am Musarun in Ashama people to General, the Tim Dajin, Pipa. So in Asha Suraga, P 50% of Taidu DNA in a therapy in Asha to a Shatui. Saru 50% of patient here, Saru Kurenga, no, tap your intensify Meloda. Meloda. Tajamo, Pajam Pillar, Sarah Chimabina, to machine name. Hypoglycemia let out the patient who let Sarah Chinasi in the. By that way, you have a therapy in Asha. Tajamlo, prolong hypoglycemia, don't allow you like you now. Sarah significantly increase microvascular and macrovascular complication and petoma. Tajamu, therapy in Ayam Pisivani. Tajam, the not in it topic today. Overcoming in Ashao, General Blujam Leso, early single combination therapy in Taidu TMGA, da by the no strategy to Piovare, the Jambo General Paleso, the overcoming in Ashao to about single combination therapy, the Gay Yeji, so not binding my Timbiala. So, Pagangle, Bounty, Bowie, who previous speaker has been elaborated, not through the Pinde Shiche, but in the Shichema, online, Chauchelogatu, Kawapetwari, right? So I'm forming the Mura paint, Tenia Marati. Sabunai, we are paint, Tenia Marati. DPP4 inhibitor 9 နေရာလောက်မှထိ SGLT ကတနေရာထိပေါင်းလိုက်လို့ရှိရင်ဆရာတို့6နေရာလောက်ထိတဲ့ကြောင့် multiple target ကိုရနိုင်တယ်ဆရာတို့ကပြောတာဆရာတို့ဒီခုနကပြမဖော်မင်ကို1000ပေးတယ်မရရင်ဆရာ2000တင်တယ်အဲ့လို2000တင်မဲ့စာမဖော်မင်1000နဲ့နော်ကျွန်တော်တို့ကဆိုတော့Empagliflozin 10နဲ့ပေါင်းလိုက်ရင်ပုံကြတယ်ကြာစီးကြောပုံကြဘာလို့လဲ different mechanism ဖြစ်နေတဲ့ကြောင့်ပုံကြ different target ဖြစ်နေပုံကြကြောင့်ကျွန်တော်တို့ကဆေးကိုတင်လာတဲ့ဆိုင် combination သွားတာပုံကြိုက်တယ်ဒါကြောင့်မလို့ combine လုပ်ရင် synergistic efficacy လေးရတယ် beta cell လည်း preserve ဖြစ်တဲ့ disease ကိုလည်း delay ဖြစ်တဲ့ clinical inertia ကိုလည်းတက်တာစီရဆိုတာပြောတာဖြစ်ပါတယ်ဒါကြောင့်မလို့ကျွန်တော်တို့အနေနဲ့ပေါင်းခြင်းဒီကြိုက်တယ်အောက်မှာ synergistic effect တွေရှိတယ် multiple organ protection လည်းရတယ်နော် treatment burden လည်းကျသေးတယ် side effect တွေလည်းနည်းတယ်ဆိုတာတွေ့ရပါတယ်ဒါကြောင့်ပေါင်းမယ်ဆိုရင်ဆရာတို့ကနှစ်ခုပေါင်းတစ်လုံးနဲ့ပြီးမှလားတစ်လုံးစီခွဲပြီးမှလားအဲ့ဒါလည်းရှိသေးတယ်နော်ကောင်းခြင်းမကောင်းခြင်းမှာနော်ခုနပြောတဲ့ Empagliflozin ဆိုတာတစ်ခုတည်းနဲ့ပြီးသွားတာပေါ့ဒါမို့ Empa ကိုဆရာ10ပေးမယ်မနေ့ကိုညကို Lina ပေးမယ်အဲ့လိုလည်းရပါတယ် efficacy ကတော့အတူတူပဲတဲ့သူပြောတာဒါပေမဲ့ဆေးကလူနာဆေးကိုနှလုံးတောက်တာနဲ့တစ်လုံးတောက်တာအဲ့ဒါကွာအောင်မို့ဆရာအဲ့ဒါအားတာချက်ပေါ့ဒါကြောင့်မလို့ကျွန်တော်တို့က clinical rationale မှာသူကတော့8ချက်ပြောသွားတယ်တကယ်တမ်းတော့က16ချက်ဖြစ်နေပြီဆရာ16ချက်နဲ့ pathogenesis of the type 2 TMD 16ဖြစ်နေပြီ16ဖြစ်နေတဲ့ကြောင့်မလို့ကျွန်တော်တို့က target တွေကိုဆရာတို့ကြည့်လိုက်ဒီမှာ16ချက်ရှိအခုနောက်ပိုင်းမှာဘယ်လိုဖြစ်လာလဲဆိုရင်တစ်က3 hormone theory ဖြစ်လာတယ်အရင်တော့ကျွန်တော်တို့က insulin မရှိလို့စီးယူဖြစ်တယ် okay insulin နည်းလို့နောက်တစ်ခုကတော့ glucagon များလို့စီးယူဖြစ်တယ် glucagon များရင် hepatic glucose output များတယ် glucagon က anti insulin effect ရှိတယ်ဒါကြောင့် glucagon တက်တာကိုကျွန်တော်မကြိုက် beta cell ကနေပြီး insulin မထုတ်ဘူး alpha cell ကနေ glucagon ကိုထုတ်တယ်အဲ့ဒါနောက်ဆုံးတစ်ခုကတော့ incretin နည်းလို့စီးယူဖြစ်တယ်ဆိုတော့3 hormone theory ဖြစ်သွားတယ်3 hormone theory ကို cover လုပ်နိုင်တော့စီးယူဆေးသည်Number 1 GLP-1 Number 2 DPP-4 နှစ်မျိုးပဲရှိဒါကြောင့်မလို့ကျွန်တော်တို့2026က diabetes တွေမှာခုတဲ့အခါမှာအဲ့ incretin base ကထိပ်ဆုံးမှာရောက်လာထိပ်ဆုံးမှာဘာလို့ရောက်လာလဲဆိုတော့တစ် pathogenesis ရဲ့နော်9နေရာ10နေရာလောက်ကိုလည်းသူက cover လုပ်တယ် attack လုပ်တယ်နံပါတ်2 3 hormone theory ကိုလည်း cover ပေးတာဒီ incretin base တစ်မျိုးပဲရှိရဆရာမဖော်မင်းလည်းမရောက်စာပတိုင်းပြလည်းမရောက်even though SGLT လည်းမရဒါကြောင့်မလို့ incretin based therapy ကိုကျွန်တော်အရန်သုံးတယ်ကြိုက်ဆုံးကတော့ GLP-1 မို့ဆရာ GLP-1 ကိုကြိုက်ဆုံးပဲသူခဏပြောသွားတယ်ဒီကိုပြီးရင်ဆရာတို့ရှိပြီးသား DPP4 လေးကို incretin level လေးကိုပဲပို့ဆိုးမတော့ထိန်းတာနော်ဒါပြောပါတော့ physiological dose ပဲတကယ်လို့ GLP-1 ထိုးလိုက်ရင်အပြင်ဘက်ကနေအများကြီးပေးပလိုက်တာ pharmacological dose ရသွားတဲ့ကြောင့်ဒါကြောင့် mortality ကကျတော့ GLP-1 ပေး mortality ကျဒီဘိုးပေးမကြောက်ဘူးဆရာဒီဘိုးပေးကတော့စိတ်ပဲဖြစ်တာပဲဖြစ်တဲ့တကြောင်အကြိုက်ဆုံးကျွန်တော်ပြောပါဆို incretin base နံပါတ်1ဖြစ်ပါတယ်နံပါတ်2အကြိုက်ဆုံးက SGLT2 ဖြစ်ပါတယ်ဒီနှစ်ကောင်အကြိုက်ဆုံးပဲနံပါတ်3ကတော့ still we are using metformin လည်းကြိုက်အဲ့တော့အကြိုက်ဆုံး3မျိုး combination ပြောပါလို့ပြောရင်တစ် metformin နဲ့ semaglutide or tirzepatide နံပါတ်3 SGLT2 that's the best အကောင်းဆုံးပဲအဲ့လိုဟိုစာပနာယူရရောက်ဆိုစာပနာနံပါတ်4ရောက်သွားပြီနံပါတ်4ရောက်နေပြီEmpagliflozinဒီနံပါတ်5လောက်မှဖြစ်နေပြီဧကားပို့တာမ30လောက်ဖြစ်နေပြီဆိုတော့အဲ့လိုဖြစ်နေတဲ့ကြောင့်ဆရာတို့ဒီနေ့သုံးရင်တော့ထိတ်ဆုံးအကြိုက်ဆုံး3ခုကကျွန်တော်ဒါကိုပြောချင်တာဖြစ်ပါတယ်ဒီမှာဆိုရင် beta cell ကကြလို့နော် alpha cell ကနေ glucagon တွေထွက်လို့ peripheral insulin resistant ဖြစ်လို့ hepatic resistant နဲ့ hepatic မှာ gluconeogenesis ဖြစ်လို့များလို့and then renal မှာ absorption ကတော့ SGLT ကပြန်ဆုပ်လို့ incretin နဲ့လို့ adipose expansion or lipotoxicity ဆိုတာပြောပါတယ်သူက excess free fatty acid တွေရှိရင်နော် impair the insulin secretion in liver muscle and beta cell ကြောင့်ဒါကြောင့်လည်းသူကစီးကျိုဖြစ်တယ်လို့ယူဆပါတယ်မိမ insulin resistant ဖြစ်တယ်ဒါကြောင့် appetite တွေကို dysregulation ဖြစ်တယ်သူကဘာလဲဆို impair satiety signaling and increase appetite and food intake ဖြစ်တယ်ဒါကြောင့်စီးကျိုဖြစ်တယ်ဆိုဒီမှာပါလာနောက်တစ်ခုကတော့ဒီမှာပါလာလဲဆို chronic low grade inflammation type 2 DM ဆိုတာ one of the inflammation ဖြစ်တယ်အဲ့ဒါလည်းပါလာနောက်တစ်ခုက oxidative stress တွေ excessive oxidative stress ရှိလေ damage the beta cell and impair the insulin secretion ဒါကြောင့်မလို့oxidative stress ကလည်းကျွန်တော်တို့ကပြဿနာတစ်ခုဖြစ်လာတယ် gut microbiome dysregulation ဖြစ်ရင် dysbiosis alter the metabolism inflammation and insulin insensitivity ဒါကြောင့်မလို့နောက်ပိုင်းမှာ probiotic တွေကလည်းပါလာမယ်လို့ကျွန်တော်တို့ယူဆတယ် treatment of the type 2 DM နောက်တစ်ခုက impair adipokine signaling and the dopamine signation amylin deficiency reduce glucose and islet cell inflammation လို့16ချက်တောင်ဖြစ်နေပါပြီကျွန်တော်တို့အနေနဲ့ဒါကြောင့်မလို့ဒီရက်ပိုလဲဆိုးလာနိုင်တယ်ဒါကြောင့် treatment ကိုဆရာတို့ကြည့်လိုက်ရင်ဆရာ GLP-1 DP4 GLP-1 DP4 metformin SGLT2 ဒါတွေပဲဒါကြောင့်ကျွန်တော်ပြောချင်တာ combination မှာ S ကဒီ3ကောင်ပဲဒီ16ခုလုံးကာဗာဖြစ်နေတဲ့အများစုဒီကျွန်တော်တို့က GLP-1 မတုံးနိုင်တော့ DPP4 ပါဆရာ and then metformin SGLT2 is the best ဒီ16ချက်ကိုကာဗာပေးရဲ့အကောင်းဆုံးအချက်တွေမှာပါတယ်ဆိုတော့ကျွန်တော်တွေ့ပြသေးဒါကြောင့် combination ညာဆရာတို့မျိုးစုံရှိတယ် metformin SGLT2 ဆရာပေါင်းပါလား metformin D4 ပေါင်းပါလား metformin and GLP-1 ပေါင်းပါလား SGLT2 နဲ့ GLP-1 ပေါင်းပါလား SGLT2 နဲ့ DPP4 ပေါင်းပါလားကျွန်တော်တို့ဒီနေ့ပြောနေရတော့ SGLT2 နဲ့ DPP4 ပေါင်းနေဆို combination ကိုတွားနေအောင် so combination ကိုတွားရင်နော် complementary action ရှိတယ် no overlapping toxicity ဖြစ်ဘူး cardiovascular protection ဖြစ်တဲ့အတွက်ကြောင့်မလို့အကောင်းဆုံးဒီလို combination ကိုဘယ်လိုလူတွေမှာသုံးသင့်တယ်လဲဆိုရင် patient center selection မှာ obese ဖြစ်တယ်လူ diabetes and obese ရဒါတွေသုံးအောင် ASCVD heart failure CKD အဲ့လိုလူမျိုးတွေမှာဆရာတို့ကကျွန်တော်တို့ဒီ combination ကိုရွေးသုံးနေဆိုတာပြောချင်ပါတယ်2026 के diabetes management का previous speaker has been elaborated ပေါ့နော်ကျွန်တော်တို့ကဘာဖြစ်လာလဲဆိုရင် cardio renal centric approach ဖြစ်လာတယ်ဒါကြောင့်မလို့ combination က early combination therapy approach ပေါ့ဒီကတော့ metformin GLP-1 SGLT2 ဒီ3ကောင်ဒီအကောင်းဆုံးဖြစ်ပါတယ်ဆိုတော့2026မှာကျွန်တော်တို့က approach မှာပြောပြီးသားဖြစ်ပါတယ်အဲ့တော့ကျွန်တော်တို့ကနောက်တစ်ခုကျွန်တော်ပြောချင်တာကဆရာတို့ proactive နဲ့ non reactive ကိုကျွန်တော်အရင်တစ်ခေါက်က talk မှာလဲကျွန်တော်ပြောပါတယ်တစ်ကပါလဲ reactive ဆိုတာနောက်ဆုံးနေတာတို့ကဆရာဖြစ်မှပေးတာဆိုတော့ renal ထိမှ renal ထိရင်ကျွန်တော် SGLT2 ထားစားမယ် renal ထိလို့ရှိရင် SGLT2 ထည့်စားမယ် renal ထိရင် Linagliptin ကိုပြောင်းမယ် alright ဒါကဖြစ်မှကျွန်တော်စပေးတာအခု approach အဲ့လိုမဟုတ်သူကဖြစ်နိုင်ခြေရှိတယ်လို့ကြိုပေးတာဆရာအရင်တော့ကျွန်တော်တို့ပဲပြောခဲ့တာနော်ဘာ risk မှမရှိရင် SGLT2 မပေးနဲ့လို့ပြောတာအခုအမှားပါပြီသူကဘာပြောလဲကြိုတာပေးလိုက်တော့ကြိုတာပေးလိုက်တော့အဲ့ဒါကိုကျွန်တော်တို့က proactive ဆို early intervention လုပ်မယ်ကြာခံလုပ်မယ် organ protection ဆိုတာအရင်စကားပြောလာတယ်ဒါကြောင့် reactive ဆိုတာ step wise သွားတာA1C ကိုကြာအောင်အရင်လုံးမကြာရင်နောက်ကထပ်တင်မယ်မကြာရင်နောက်ကထပ်တင်မယ် very slow identification monotherapy သွားတယ်ပေါ့ proactive ဆိုအဲ့လိုမဟုတ်အစောရအတကုံချ early intensive management ပေးမယ် initial combination သုံးပြမယ် aggressively A1C ကို 6.5 ချမယ် target the multiple pathophysiological defects ဒီ2026က idea မှာဆရာတို့ကနှစ်ချက်ကြည့်ရငါထဲမှာငါဒီနေ့ကနေငါစင်ကတော့ထိုင်ငါစီးလို့မှငါကြည့်ငါထဲမှာစင်နှမျိုးပါတစ်မျိုးကစီးလို့ကြတယ်စေတစ်မျိုးက organ protection စေအဲ့ဒါဖြစ်နေပြီအဲ့ဒါ idea ပဲအဲ့တော့ကျွန်တော်ပြန်ကြည့်နေကျွန်တော်လူနာကြီးပြန်ကြည့်လိုက်တော့ကျွန်တော် metformin စာပုံနိုင်ယူရအဲ့လိုကအကျင့်ပါနေပြီကျွန်တော်ကနော်လူတိုင်းဒီ metformin dead နော် dimicron MR အဲ့ဒါဒီအကုန်လုံးဖြစ်နေအဲ့ကျွန်တော်ကဒီ2026က guideline ရတော့မကိုက်တော့ဘူးအဲ့ဒီမှာ organ protection စိမပါဘူးဖြစ်အဲ့တော့ကျွန်တော်တို့ကဘာပြန်လုပ်ရလဲဆိုတော့စီးကြုံမကောင်းရင်တော့ကောက်လွယ်တာပေါ့နော်တလုံးထပ်ထည့်လိုက်ထဲမဲ့စေ SGLT2 ပဲသိကြတယ်ပတ်သက်ရှင်ကျွန်တော် GLP-1 ထည့်မှာပဲနော်အဲ့တော့အဲ့နှစ်ခုမပါဘဲနဲ့2026ကမရတော့ organ protection စိပါကိုဆရာပါမယ်ချိုးပေးတာကို proactive လို့ခေါ်တယ်ဒါကြောင့်မလို့ proactive approach ဖြစ်တဲ့ကြောင့်ကျွန်တော်တို့အခုဆေးတို့ဘာပြန်လုပ်ရလဲဆိုရင်အဲ့လူနာတွေကကျွန်တော်ပြဿနာအဲ့နှမျိုးရှိတော့ကျွန်တော်လဲကျင်တယ်စာပုံနိုင်ယူတော့လဲကျင်တော့ဆရာကျွန်တော်ဆေးတွေပြတ်မှာကြောက်လို့တစ်လသာကြိုဝေထားတော့ကျွန်တော်ပြောင်းလို့မရဖြစ်တော့နောက်တစ်ခါကျရင်ကျွန်တော်အမြင်ကတ်လာအောင်သိလားတစ်နှစ်စာကြိုဝေထားတဲ့ဆိုတာရှိသေးတယ်အဲ့ဒါဆိုလည်းခင်ဗျာကြောက်ကထိမှာလို့ပါဇက်ကအပေါက်ကဆိုးသွားအဲ့ဒါလည်းဘာပြန်ပြောလဲအဲ့ဒါဆိုလည်းပြန်လဲကြည့်လိုက်မယ်ဒါမှမဟုတ်လေယောက်ျားတဲ့စာပုံနိုင်ယူရတောင်းနေသူ့ပေးလိုက်မယ်နော်တဲ့အဲ့လိုလည်းရှိသေးဆိုတော့အဲ့ဒါကျွန်တော်တို့မှာဒုက္ခတွေရောက်နေတာဒါပေါ့နော် ဒါကြောင့်မလို့ကျွန်တော်တို့က proactive care ဖို့အတွက်ဆရာ organ protection focus လုပ်ဖို့တော့ဒီ2026မှာအကြီးအကျယ်ပြောနေ previous เนาะကျွန်တော် talk မှာလည်းကျွန်တော်ပြောတယ် nice guideline 2026ကစတွေ့ရ metformin SGLT ပေးပါတော့ဖြတ်ကိုပြောတာအပြတ်ကိုပြောတာဒါကြောင့်မလို့ဆရာတို့ရဲ့ approach တွေမှာလည်းဆရာတို့ဒီ1 SGLT ငါပါပြီလားနံပါတ်2 GLP-1 ပါပြီလားဆိုတာဆရာတို့တွေ့ရမှာဖြစ်ပါတယ် by that way ကျွန်တော်က proactive လုပ်ခြင်းအပြင်ဆရာတို့ဒီနောက်ပိုင်းမှာသူကလောလောဆယ်တော့ပတ်စံကုန်တယ်ဆရာ SGLT ထည့်လိုက်ပတ်စံကုန်တော့နော်တို့တော့နောက်ပိုင်းမှာ infarct ရတော့မယ်နောက်ပိုင်းမှာ stroke ရပါမယ်နောက်ပိုင်းမှာကျွန်တော်တို့ dialysis လုပ်တာတဲ့ဆိုင်တော့သူကအများကြီးအားသာသေးတယ်ဒါကြောင့်သူတို့နည်းနည်းရှင်းပြပါစောစောဒီဟာကိုကြိုပေးခြင်းအပြင်သူတို့အဲ့ဒါဆိုကြောက်တယ်ကျွန်တော်ကပြောရင်မချောက်ရဘူးလေမချောက်လို့လည်းမရဘူးမချောက်ရင်သူကမကြောက်ဘူးဆရာအဲ့တော့ခင်ဗျာဒါမတော့ရင်ခင်ဗျာကြောက်ကထီသွားရင်တခါဆေး8000နော်တပတ်ကို3ခါမသေးမချင်းစေးတစ်လ10သိန်းဆိုတော့လန့်အောင်အဲ့ဒါလည်းတောက်ပါမယ်ဖြစ်တော့အဲ့ဒါလည်းကျွန်တော်ကမကြောက်ဆိုတော့ဒီ proactive နဲ့ reactive ကိုကျွန်တော်တို့ရဲ့ကုသချက်တွေက proactive ဆိုတာ early detection လုပ်တယ် immediate lifestyle and medical intervention ပြီး optimize and control လုပ်တယ် by that way you can have a stable tightly controlled A1C ရလိမ့်မယ် reactive is a delayed diagnosis symptom driven intervention and fluctuating control ဖြစ်တဲ့ကြောင့် fragile glucose တွေရproactive ဒီ prevention focus လုပ်တယ် cardiac ကိုငါတို့ကြိုကာမယ် renal ကိုကြိုကာမယ် stroke ကိုကြိုကာမယ်ဒါကြောင့် organ protection စိတ်ငါထဲကိုထဲမယ်ဆိုပြီးရှိသမျှလူတိုင်းအဲ့ဒီလူကောက်ထည့်ပလိုက်ရ and ရှိသမျှတော့ GLP-1 နေကောက်ထည့်လိုက်ပတ်သက်မရှိတဲ့လူကလွယ်လို့ပေါ့ဆရာပတ်သက်မရှိရင်တော့လည်းဘလို့မှမတတ်နိုင်ဘူး by that way ကျွန်တော်က lower incident တော့ macro and micro စာဖြစ်တဲ့ highly treatment adherence ရှိတယ် reactive ကတော့ဖြစ်မှကူတာ complication management focus ဖြစ်သွားတယ်သူက renal ထိမှเนาะကျွန်တော်တို့ကเนาะ creatinine တက်မှပေးတယ် and then ECG ချင်းရရမှကျွန်တော်ပေးတာကိုကျွန်တော်ကမကြိုက်ဘူးဖြစ်နေဒါကြောင့် proactive ဒီ more sustainable and lower the disease burden ဖြစ်တာကိုတွေးရှိရပါတယ်ဒါကြောင့်လဲ2022 guideline ကဘာပြောလဲဆို durable ဖြစ်ရမယ် multiple pathophysiology ကို attack လုပ်ရမယ် and then adherence ကောင်းလုပ်ရမယ်complementary ဖြစ်ရမယ်လို့ပြောပါတယ် synergistic effect နဲ့ဒါကြောင့်မလို့ကျွန်တော်တို့ကဆေးတွေကိုပေါင်းကြည့်မယ်ပေါင်းကြည့်ရကမှဆရာတို့ကြည့်အစိမ်းရောင်เนี่ยကောင်းနေတယ်ဒီမှာရေးထားတယ်အစိမ်းရောင်မှာသူကဗာရေးထားအစိမ်းရောင် benefit ဖြစ်တယ်တဲ့ organ protection ပေးတယ်တဲ့ high efficiency efficacy ဖြစ်တယ်တဲ့ low glycemic risk ရှိရတဲ့ weight loss လည်းရတယ်နောက်ပိုင်းမှာဆေးရပါတော့ low cost လည်းဖြစ်တဲ့ကြောင့်အစိမ်းရောင်တွေကိုဆရာတို့ရွေးရမှာဖြစ်ပါအဲ့တော့ဆေးရောင်တွေရွေးခြင်းထိတ်ဆုံးက metformin ကြီးတော်တော်စိမ့်နေဒါတော့ progression of CKD ကိုကြည့်တယ် ASCVD heart failure glucose lowering efficacy hypoglycemia weight and cost မှာအဲ့အချက်တွေအကုန်လုံးသူလိုက်ကြည့်တဲ့အခါမှာ metformin စိမ့်နေ SGLT တော်တော်ကြီးကိုစိမ့်နေ GLP-1 တော်တော်စိမ့်နေအဲ့တော့အောင်စိမ့်လုံးပါဆရာဒါတဲ့နောက်ထပ်စိမ့်တာ DB4 ပဲအောက်မှာဆရာစာပုံနိုင်ရောက်ကြည့်လိုက်အစိမ့်ကနှစ်ခုပဲပါတယ်အကုန်လုံးညီပါတယ်ညီမကောင်းဆရာညီမကောင်းတီဆက်ဒီမှာလည်းညီရပါနေမကောင်းဆရာဒါကြောင့်မလို့စိမ့်တဲ့ဆေးလေးတွေကိုဆရာရွေးသုံးနေဆိုရင်တော့ဆရာတို့ဒီထိတ်ဆုံးမှာဘာဖြစ်နေလဲ metformin SGLT and GLP-1 ထိတ်ဆုံးဖြစ်နေရဲ့ GLP-1 မတက်နိုင်တော့ဆရာ DB4 ကိုသုံးတာကောင်းပါတယ်ဒါကြောင့် early combination မှာကျွန်တော်အထက်တက်ပြောသလိုကြောင့်၃ခုပေါင်းတာဒီအကောင်းဆုံးဖြစ်တဲ့ DB4 နဲ့အကောင်းဆုံးဖြစ်တယ်အဲ့တော့ပေါင်းကြည့်ပါပေါင်းကြည့်ရင်ကျွန်တော်ဒီနေ့ပြောမယ့်ဟာအလဲဟာပေါ့ DB4 နဲ့ SGLT နဲ့ပေါင်းထားတဲ့ Empagliflozin နဲ့ Linagliptin ကိုပေါင်းရင်နော်ဆရာ defects of omnium ortes ကိုကျွန်တော်ကြားသေးတယ် insulin ကြားတယ် glucagon တက်တယ် incretin တက်တယ်အောက်မှာကြည့်လိုက် low risk of hyperglycemia reduce the glycemic variability provide the weight loss positive side effect တွေရှိတယ် decrease nutrient absorption ကောင်းတယ်ပေါ့ဟိုဘက်မှာပြောတဲ့၃ခုသာပေါင်းကြည့် DB4 ရဲ့ metformin ရဲ့ SGLT ကိုပေါင်းရင်7 defect of omnium ortes ကိုကြားစီတယ် a lot of ကျွန်တော်တို့ကောင်းတဲ့အချက်တွေရှိတဲ့ကြောင့်ကျွန်တော်တို့ဒါကြိုက်တယ်ဒါကတော့တိတ်အရန်ကြိုက်တာမဟုတ်အခုလောလောဆယ်တော့ကျွန်တော်အရန်သုံးများနေကြတယ်ဟလာ Linagliptin နဲ့ metformin အပေါင်းနေတာဒါပေါ့အခုဒီနေ့ပြောမှအလဲကြိုက်ဟိုဘက်အစုံဆုံးကြိုက်ဆုံးပဲအဲ့တော့ကျွန်တော်ဒီနေ့ကျွန်တော် approach က metformin SGLT Linagliptin အဲ့လိုဖြစ်နေကြမလို့တော့ Empagliflozin Linagliptin အပေါင်းဖြစ်တဲ့ FTC တစ်လုံးပေးလိုက် metformin ပေးလိုက် this is best ပေါ့ဒီရက်ပိုကောင်းတာတော့ GLP-1 ပေါ့နော်တခုတည်းထားမှာ SGLT ကိုပေးရင် glucagon တက်တယ်သူခုနပြောတယ်ဘာလို့တော့ SGLT ပေးရင် insulin နဲ့မထွက်တော့ glucagon တက်လာ တို့တော့ DPP ကိုပေးလိုက်ရင် glucagon ပြန်ကျသွားဆိုနှစ်ခုပေါင်းတာဒီ the best ပဲဒါကြောင့်မလို့ combination ပေးတာဒီကောင်းတယ်ဆိုတာပြောပြသည်ဒါကြောင့် rational လေးမှာဆရာတို့ဒီဘက်က SGLT ပေးလိုက်ရင်စီးကြိုလည်းကျမယ် A1C လည်းကျမယ် weight လည်းကျမယ် blood pressure လည်းကျမယ် DPP ကိုပေးလိုက်ရင်နော် insulin ကတက်လာမယ် glucagon ကျမယ်နှစ်ခုပေါင်းပေးရင် glycemic control ကောင်းနေမကောက်ဆရာတို့ weight ကော low glycemic effect ကိုရတယ်နှစ်ခုကိုတစ်လုံးနဲ့ပေါင်းပေးလိုက်ရင် FDC လုပ်လိုက်ရင်တော့ they target the multiple key defect or type 2 DM and then reduce the pill burden and then enhance the patient compliance ဆိုကြောင့် FDC ဒီနေ့ပြောတဲ့ Empagliflozin ဒီတော်တော်ကြီးကိုကောင်းတဲ့ထဲမှာပါတယ်ဆိုတော့ကျွန်တော်တင်ပြရသေးဘလို့လူတွေကိုဆရာရွေးသုံးမလဲဒီခုနဒီနေ့သွားမယ်နော် Empazox L ကိုဘလို့လူတွေရွေးသုံးခြင်းလဲဆိုရင်ကျွန်တော်ဒီလိုလူတွေကိုရွေးသုံးခြင်းနဲ့နှစ်မျိုးရှိတယ်ဒီဘက်က diabetes and complication ရနေတဲ့လူတွေအဲ့ဒါဘာလို့လူတွေလဲဆိုတော့ diabetes established cardiovascular disease diabetes chronic kidney disease အဲ့လိုလူတွေဆရာတို့ရွေးသုံးရမယ် and then diabetes နဲ့ဝတ်ရတဲ့လူတွေ diabetes နဲ့ hypoglycemia ခဏခဏရတဲ့လူတွေဒီလိုလူတွေမှာဆရာတို့ဒီဆေးကိုရွေးသုံးနေတယ်စီးကြိုအောက်ဆုံးကတယောက်ကစီးကြို control မရတဲ့လူတွေဆရာဆေးတွေပေးထားတယ်ပေးတာနဲ့ဆရာ control မရရင် control မရရင်သူကထပ်ပြီး add လုပ်လို့ရတယ်သူက combination therapy ကိုဘယ်လို guideline မှာပေးခိုင်းလဲဆိုရင်ဆရာတို့လိုချင်တဲ့ target တဲ့ A1CD 1.5% ကျော်တက်နေ early combination နဲ့စပါလို့ပြောပါတယ်ဆိုတော့ဆရာလိုချင်တာ7 okay သူ့ရဲ့ A1C က 8.5 ဖြစ်နေတယ်ဆိုတော့ 1.5 above the your target ဆိုရင် you have to use the early combination therapy ပေါ့အဲ့တော့ကျွန်တော်မြန်မာ guideline မှာလည်းဘယ်လိုပြောထားလဲ A1C 8.5 အောက်မှာ1နဲ့စ 8.5 နဲ့ 10 2နဲ့စ10ကျော်ရင်3နဲ့စသူ့ insulin ထိုးလို့ပြောထားတယ်အဲ့ဒီ guideline ကိုဆရာတို့ကြောက်ပါအဲ့တော့ပြောချင်တာလူနာတယောက်လာရင်ဆရာတို့က metformin ရင်ပေးလိုက်မယ်3လစောင့်မယ်မရတော့မှနောက်တစ်ခုတင်မယ် no that's not true စတွေ့ရ A1 ကိုကြည့်ပြီးဆရာတို့ဆုံးဖြတ်ဖို့အတွက်ကျွန်တော်တို့တင်ပြပြရသေးဒါကြောင့်မလို့ကျွန်တော်တို့က ID patient တွေက ASCVD heart failure ရှိရလူ CKD ရှိရလူ early type 2 DM နဲ့လူတွေကကောင်းဆုံးဖြစ်ပါတယ်ပေါ့နော်အဲ့တော့75% of cardiologists တွေကလည်းတဲ့ဒီ combination အရန်ကြိုက်တယ်အဲ့ဒါကကျွန်တော် expert opinion မှာအကုန်လုံးကျွန်တော်တွေ့ထားပါတယ်75% cardiologists တွေအရန်ကြိုက်တဲ့ထဲမှာဒီ result ပါပါတယ်ဒါကြောင့်မို့ FDC နဲ့ကျွန်တော်တို့ separate ပေးတာကောင်းတာရှိရမကောင်းတာရှိရသူကဘာလဲဆိုဆရာသူကဟိုတို့ဆို adjust လုပ်ဖို့ကြတော့ဒီကောင်ပေါင်းထားတဲ့ကောင်နည်းနည်းခက်တယ်တို့ကျွန်တော်တွေ့ရှိချက်တွေက Empagliflozin Lina 5 okay Lina dose ပြောင်းစရာမရှိဘူး Empagliflozin Lina 5အရင်မကွာဘူးအရင်မကွာကြောင့်ဆရာတို့စိတ်ချလက်ချ Empagliflozin တခုပဲပေးလိုက်ရတယ်ပေါ့နော်အဲ့တော့ pros and cons တွေကကောင်းတာကဒါ combination ကောင်းတဲ့အချက်တွေ combination မကောင်းတာ side effect တွေရှိနိုင်တယ်နောက်ကျွန်တော် hypoglycemia ရရင်ဘယ်ကောင်ကြောင့်မသိဘူးဘယ်ကောင်ဖြုတ်လို့ဖြုတ်ရမှမသိဘူးဆရာတို့ Empagliflozin ပေးလိုက်လို့ခုနပြောတဲ့ဟို genital tract infection တွေဝင်သွားပြီလို့သူက Lina ပါထပ်ဖြုတ်ရမလို့ဖြစ်နေတယ်အဲ့ဒါရအားနေချက်တွေကတစ်ခုချင်းနဲ့တိုင်းတော့မကောင်းတဲ့ချက်တွေပေါ့နော် pros and cons တွေရှိပါတယ်ဒီမှာ single နဲ့ two drug combination မှာကောင်းနိုင်မကောင်းနိုင်ကျွန်တော်တို့အချိန်ချင်းပြောပြီးသားဖြစ်ပါတယ်နော်အဲ့တော့ cardiac မှာသုံးလို့ရလားရတယ် Empagliflozin အကုန်ကောင်းတယ်ဆိုတာကို evidence ကပြောထားတယ် cardio-renal ကို protect လုပ်တယ် and then reduce နော်ကျွန်တော် mortality ကိုကျတယ် all the ကျွန်တော်ကြည့်လိုက်တဲ့အခါမှာ renal Empagliflozin ကအကုန်ကျတယ်ဆိုတာကျွန်တော်တို့အချိန်ချင်းပြောပြီးသားဖြစ်တယ်ဒါကြောင့်မလို့ SGLT2 ASCVD heart failure CKD ရှိရင်ဆရာတို့ SGLT ကိုသုံးရမှာဖြစ်ပါတယ်ဒါသုံးရမယ် Lina ကလည်း all the safe နော်ကျွန်တော်တို့အခုနောက်ပိုင်းကျွန်တော်တို့သုံးနေကြရင် DPP ဆရာတို့ရွေးရင်ဆရာတို့ဘာပဲရွေးရသေးလား Sitagliptin ပဲရွေးတယ် Betagliptin လည်းဆရာတို့မရွေးဘူး Lina လည်းမရွေးဘူးဒါ Lina ဆရာတို့ဘယ်တော့မှရွေးမှာလဲဆိုရင် renal ထိမှရွေးမယ်ပေါ့နော် renal ထိမှအဲ့ဒါအကျင့်ဖြစ်နေ trend ဖြစ်နေအဲ့ဒါ trend ကကျွန်တော်တို့ပဲစားခဲ့တာပဲကျွန်တော်တို့ပဲအခုနောက်ကနေရှေ့တစ်မျိုးနောက်တစ်မျိုးပြန်ပြောအောင်လို့ဖြစ်နေလုံးလို့ရပါတယ်ပြဿနာမရှိဘူးတိုးတော့စစ်တာရဲ့ပြဿနာပါလဲဆိုတော့ဆရာ renal ထိရင်တို့တဝက်လျှော့ရတယ်နော် renal EGF ကကြာသွားပြီဆိုတို့တဝက်လျှော့ရတယ်Lina လျှော့တယ်မလို့အဲ့တော့စတဲ့ကိုက Lina ပေးလိုက်ပြီးနေကိစ္စ 5mg ဆရာရဲ့လဲကြည့်စရာလည်းမလို့ liver ထိ renal ထိ cardiac ထိအဲ့ဒါအမှန်ဆုံးပဲဒါကြောင့်သူခုနပြောပါတယ်ဆေးဥပေါ်ရောက်ရင်တဲ့တောက်တဲ့ဆေးတွေမှာဘယ်ဟာစိတ်အဖြစ်ဆုံးလဲLinaပဲဆရာ ကျွန်တော်တို့လင်နာပဲပေးရတော့ဆရာမဖော်မပေးတဲ့လက်တိအစီဒိုစီကကြောက်ရသေးတယ်အဲ့ဒီကတူကလည်းမရဘူးတော့ဒိုင်မိုက်ခရိုပါပေးလိုက်ရင်လည်းဟိုက်ပေါ်လည်းကြောက်တယ် the safe ကလင်နာပဲဆရာဒါကြောင့်ကျွန်တော်တို့နောက်ပိုင်းနေမှာလင်နာပဲပေးပလိုက်တော့စစ်တာကူတော်မှနည်းနည်းအသုံးနည်းလာတယ်ပေါ့နော်နောက်ကစစ်တာနဲ့လာရင်တော့တမျိုးပြန်ပြောအဲ့လိုမဟုတ်ပါဘူးဆိုတော့လင်နာကနော်လင်နာကကာဒီယက်ကို safe ဖြစ်တယ်ဒါကြောင့်မို့ empathy ကာဒီယက်ကိုကြားတယ်လင်နာဒီကာဒီယက် safe ဖြစ်တယ်နှစ်ခုပေါင်းအရန်ကောင်းအဲ့နှစ်ခုပေါင်းလို့ရှိရင် ASCVD heart failure နဲ့ stroke တွေမှာကောင်းတယ်ဆိုတာကျွန်တော်တင်ပြပြရသေးrenal မှာလည်းကောင်းတယ်ဆရာတို့သိရဲ့ empathy renal ကိုကြားတယ်လင်နာဒီကျွန်တော်တို့ကဘာလဲဆိုလို့ရှိရင်ဒါလင်နာဒီကာဒီယက်ကို renal safe ဖြစ်တယ်ပေါ့နော်ဒါကြောင့်မို့ကျွန်တော်သုံးလို့ရတယ်တခုပဲရှိရဲ့ဆရာတို့ guideline မှာလေ guideline မှာတခုသတိထားမှာကျွန်တော်တို့SGLT2 ကိုဒါလင်နာလေး very safe ပေါ့နော် SGLT ကိုဆရာသုံးလို့ရှိရင်ဆရာတို့တစ်ချက်ပေါ့နော် EGFR ဘယ်လောက်မှဖြစ်ရမလဲဆရာအနည်းဆုံး20ကျော်ရမယ်နော် empathy 20 depathy 25 and then ကျွန်တော်တို့က kenathy 30အဲ့မှာကျွန်တော်တို့သွားမှာဖြစ်ပါတယ်ဒါကြောင့်မလို့ကျွန်တော်တို့ကဘာပြောလဲဆိုတော့ဆရာတို့ပေးကန်ဒီမှာဒီဆေးကိုပေးကန်ဒီမှာ EGFR တော့ဆရာကြည့်ရမယ် EGFR 20ကျော်ဝင်ဆရာပေးလို့ရ20အောက်တော့ပေးလို့မရဘူးပေးနေနဲ့ကြာသွားရင်တော့ပြဿနာမရှိဘူးရတယ် transplant လုပ်တဲ့ဒီစက်တာပေးဘာမှပြဿနာမရှိလို့ခေါ်တယ်ဒါကြောင့် EGFR ထူတော့ဆရာတို့တွေ့ရမယ်နံပါတ်1သူက albuminuria ရှိတဲ့လူတွေမှာ evidence ပို့ဖြစ်တယ် evidence မရှိသိမဖြစ်ဘူးအဲ့ဒါလည်းသူကဘာပြောလဲဆိုတော့ albuminuria 200ကျော်ရမယ် and then ကျွန်တော်တို့က EGFR 20ကျော်မှာဖြစ်ပါတယ်ဒီလိုလူတွေမှာတော့ဆရာတို့ရွေးတော့မှာဒါကြောင့်မလို့နှစ်ခုပေါင်းလိုက်လို့ရှိရင်EGFR protein တွေလည်းရှိမယ် EGFR more than 20ဆိုရင်တော့ empalina အပေါင်းဒီ very safe ဖြစ်တယ်ဆိုတာကျွန်တော်တို့တင်ပြပါရစေနောက်တစ်ခုကတော့ liver ပေါ့နော် liver သူလည်းပြောသွားတယ် liver မှာ very safe နော် lina ဒီ very safe ဖြစ်တယ်ကျွန်တော်တို့အခုနောက်ပိုင်း2026 guideline ကိုဆရာတို့ကြည့်လိုက်ရင်နော် mesel ကိုကုရင်ဆရာတို့စီးကြိုရှိလားမရှိလားကြည့်ပါ mesh ဝင်နေလားမဝင်လားကြည့်ပါအဲ့တော့ mesel ကိုကုရင်စီးကြိုမရှိဘူးဆိုရင်တော့ဆရာတို့သုံးရမယ့်ဆေးဒီ GLP-1 နဲ့ GIP ပဲဖြစ်တယ်စီးကြိုရှိသွားရင်အလယ်မှာရှိတယ် GLP-1 GIP ဘာကို prefer ဖြစ်တယ် you stay you paraglitazone you stay to SGLT2 သုံးလို့ရတယ် mesh ဖြစ်သွားရင်တော့ restmatino နဲ့ GLP-1 ပဲဆရာတို့သုံးရမှာဖြစ်ပါတယ်ဒါကြောင့် muscle D ဆိုရင်တော့ဒီလိုဖြစ်တယ် mesh ဖြစ်သွားရင်တော့ဆရာတို့ restmatino အဲ့ restmatino လည်းဗမာပြည်မှာလာတော့မှာဆရာမပူနဲ့တော့ FDA ကိုတင်ထားပြီးသားကြီးဆိုတာကျွန်တော်တို့နောက်ပိုင်းမှာကျွန်တော်သုံးရတော့မှာဖြစ်ပါတယ်ဒါကြောင့် liver မှာ diabetes သမားတယောက် muscle D ဖြစ်ရင် SGLT2 ပေးလို့ရတယ်ဆိုတော့ကျွန်တော်တင်ပြရသေး and then lina လည်းနော် very safe you don't need no that drug dose adjustment လုံးဝမလိုဘူးဆရာ liver impairment ဒါကြောင့် empalina ပေါင်းလိုက်တဲ့ဟာဒီ liver မှာ very safe muscle D or liver impairment ကိုဆရာတို့သုံးလို့ရတယ် and then diabetes သမားတွေမှာတော့ကျွန်တော်ခုနပြောသလို combination ကိုဆရာတို့သုံးကြည့် combination သုံးရင်သူတို့ဒီနှစ်ခုပေါင်းလိုက်ရင် A1C ကိုဘယ်လောက်ကျလဲဆိုတော့ 1.08 ကျ25က 1.08 ကျ10ပေးရင် 1.06 ကျ0.02 ပဲกว่าတယ်ဒါကြောင့်ဆရာ25ပေးမပြမလို့ Empa 10 Lina 5 is okay ပြဿနာမရှိအဲ့ဒါဒီတစ်ခုချင်းပေးရတယ်ပိုကောင်းတယ်ဘယ်လောက်မြန်မြန်ကျနိုင်လဲဆိုရင်14ရက်အတွင်းမှာ45 mg ကျနိုင်တယ်ဒါကြောင့်မလို့ဆရာတို့နော် effect ကို14ရက်အတွင်းမှာရနိုင်တယ် and then target achievement ကလည်းအဲ့လိုပေါင်းပေးလိုက်ရင် 61.8% ရတာကိုကျွန်တော်တို့သွားတွေ့ရတယ် and then sustainability မှာလည်း52ပတ်ကြောင်ပေးတဲ့အခါမှာ A1C drip က 0.15 ပဲအတက်ကြလေးရှိတဲ့ကြောင့် very durable ဖြစ်တယ်ဒါတော့ကျွန်တော်ကတင်ပြပြရစီเนาะဒါကြောင့်မို့နောက်ပိုင်းမှာ real world study တွေအများကြီးထွက်လာတယ် real world study တွေကဘာပြောလဲဆိုရင် Facebook combination ပေးပါတဲ့ A1C ကောင်းတယ်တဲ့ side effect ကလည်းအရင်မဆိုးဘူးတဲ့ side effect ဒီအများကြီးမဆိုးတော့ကျွန်တော်တို့တွေ့ရတယ်ဒီမှာက Japanese people မှာကျွန်တော်တို့သွားပေးကြည့်ရဲ့ Empalina very well tolerated ဖြစ်တယ် side effect ကလည်းအရန်နေတယ်ဆိုတာတွေ့ရတယ်ဒီဘက်မှာလည်း Bangladesh မှာလည်းသူတို့ပေးကြည့်တယ် Facebook combination နဲ့ side effect တွေကတော်တော်နေတယ်ဆိုတာသွားတွေ့ရတယ်မရှိတော့မဟုတ်တော့ဆရာရှိတယ်ရှိတော့ Empa မှာ genital tract infection urine tract infection polyuria တွေခဏစီးခဏသွားတယ်အမြုပ်တွေထားတယ်ခဏပြောတယ် dehydration တွေရှိတယ်နော် DB4 မှာ nasopharyngeal နဲ့ upper respiratory နဲ့ headache တွေရှိရပေါ့ခုနသူပြောသွားတယ်တောင်းပေးလိုက်လို့ရှိရင်နော် ပေါင်းပေးလိုက်ရင် genital tract infection due to empathy လင်နာနဲ့ပေါင်းလိုက်ရင်ပုံနေသွားတယ်ပုံနေသွားတယ်ဘာဖြစ်လဲဆိုရင်ခုနပြောတဲ့ဘက်တီးရီးယားတွေ fungus တွေထဲမှာ DBV4 တွေပါနေတယ် DBV4 တွေပါနေတော့အဲ့ဒီကောင်ကအဲ့လင်နာပေါင်းပေးလိုက်ရင် DBV4 inhibitor ပေးလိုက်တဲ့ကြောင့်မလို့အဲ့ဒါကြောင့်မလို့ပို့ပြီးတော့ empa လင်နာပေါင်းတာဒီ empa အလုံးနဲ့စာရင် genital infection နည်းသွားတယ်ဆိုတာ previous speaker side ဒါထောက်ပြသွားတာဖြစ်ပါတယ်เนาะသူမြန်မြန်ပြန်ပြောလိုက်တော့နားမလည်မှကြောက်လို့ကျွန်တော်ပြန်ပြောပြဒါပဲဒါကြောင့်ပေါင်းပြီးရင် genital tract infection ကပူနေတယ်အဲ့ဒါကိုပူပြီးတော့တက်တာတော့တွေ့ရတယ်ဒါကြောင့်ကျွန်တော်နေ့ take home message proactive ပေးပါ early combination ပေးပါဆရာတို့ညက်နေကူရင် organ protection စီပါကိုပါမယ် and then you target the multiple pathogenesis เนาะ target တွေရှိမယ်ဒါကြောင့် empalina ကိုဘယ်လိုလူတွေမှာပေးတင်လဲ DM with renal impairment each of 20 ကျော်ရဲ့လူ protein ရှိမှာအကောင်ဆုံးပေးနိုင်တယ် ASCVD ရှိရဲ့လူ elderly DM obese DM DM with frequent hypoglycemia DM with muscle D DM with A1C target က 1.5% above the target မှာပေးပါ is very safe and well tolerated လို့ပြောရင်းနဲ့ကျွန်တော်ညီကုန်းချုပ်ပါတယ်ဆရာတို့ကျေးဇူးတင်ပါတယ်
Thank you very much, Professor Google, for sharing your valuable clinical insights and experiences. Now, we will have a brief broader presentation on Empagliflozin by the team of Hetero. May I invite Assistant Product Manager, Ms. A. Tanawin, to the stage.
Hello မဲကြောက်လာကြတယ်လေးစားပါတော့ဗမောက္ခဆရာကြီးဆရာမကြီးများနဲ့တကွာဆရာဆရာမများအားလုံးကိုမင်္ဂလာပါလို့နှုတ်ဆက်လိုက်ပါတယ်ရှင်ကျမနာမည်ကတော့အေးတနာဝင်းဖြစ်ပါတယ် Hetero မြန်မာရဲ့ Assistant Product Manager ဖြစ်ပါတယ်ရှင်ကျမတို့ Hetero ရဲ့ကုမ္ပဏီကြောင်းလေးကိုစတင်ပြီးတော့အနေငယ်မိတ်ဆက်ပေးချင်ပါတယ်ရှင်ဟုတ်ကျမတို့ Hetero ပါဆိုရင်ကျမတို့ဒီကဘာနဲ့အနှံ့မှာပေါ့နော်နိုင်ငံပေါင်း145နိုင်ငံအထိကိုစပြီးရပေါ့နော် commercially present ဖြစ်နေပါရှင်ညီမတို့စီမှာဆိုရင် API လို့ခေါ်တဲ့ Active Pharmaceutical Ingredient ဇေဝကုန်ကြမ်းတွေနဲ့ပြီးတော့ Finished Dosage Formulation ကုန်ကြောပစ္စည်းတွေ Biosimilar Product တွေကိုထုတ်လုပ်ပေးနေတဲ့စက်ရုံပေါင်း306ရုံရှိပါတယ်ရှင် Globally Workforce အနေနဲ့ကတော့လုပ်သားအင်အား3000နဲ့လည်ပတ်နေပါတယ် API Product တွေနဲ့ဆိုရင်တော့450ကျော်ထိထုတ်လုပ်လျက်ရှိပြီးတော့ Finished Dosage Formulation ကတော့950ကျော်ထိထုတ်လုပ်ထားပါတယ်ရှင်ကမ္ဘာအဆင့်မီ R&D Center World Class R&D Center 6ခုလည်းရှိပြီးတော့သိပ္ပံပညာရှင်2000နဲ့ဆောင်ရွက်လျက်ရှိပါတယ်ရှင်ညီမတို့စက်ရုံ306ခုမှာဆိုရင်15စက်ရုံကကြတော့ API ကိုထုတ်လုပ်လျက်ရှိပြီးတော့23ခုကကြတော့ Finished Dosage Formulation ကိုထုတ်လုပ်လျက်ရှိပါရဲ့ရှင်အဲ့ဒီမှာ Amaros, Canva, 7 Pharma နဲ့ Hetero Healthcare ဆိုရင်ကျမတို့ရဲ့ subsidiary fund တွေဖြစ်ပါရဲ့ရှင်ကျမတို့ကဒီ Hetero company ဟာဆိုရင် API မှာဆိုရင် leadership အနေနဲ့ဥဆောင်လျက်ရှိပြီးတဲ့ခါကျတော့ဒီ drug တွေကို bar drugs အနေနဲ့ထုတ်လုပ်ပြီးတဲ့ခါကျတော့ regulated market မှာရော semi regulated market တွေမှာပါဖြန့်ချီလျက်ရှိတဲ့ leading producer ဖြစ်ပါတယ်ရှင်ပြီးတော့ global pharma leader တွေဖြစ်တဲ့နာမည်ကြီးထိပ်တန်းကော်စိတ် company တွေကိုလည်းဒီမှာကုန်ကျန်းတွေကိုပတ်မိုးပေးလျက်ရှိပါတယ်ရှင်ပြီးတော့ဒီ integration အနေနဲ့ဆိုရင်လည်း streamline development မှာကုန်ကျန်းကနေစပြီးတော့ကုန်ကြောဖြစ်တဲ့အထိအဆင့်ဆင့်ဒီကျမတို့ Hetero မှာပဲဆောင်ရွက်တာဖြစ်တဲ့ address ပေါ့နော်ဒီပြီးတော့ first to market general product တွေကိုလည်းထုတ်လုပ်ပေးနိုင်နေတဲ့ကုမ္ပဏီတစ်ခုလည်းဖြစ်ပါတယ်ရှင်essential generative ဖြစ်တဲ့ပေါ့နော် oncology product တွေကိုလည်း35ခုနဲ့အထက်ကိုလက်ရှိမှာပေါ့နော်ထုတ်လုပ်ထားဖြစ်ပြီးတော့ HIV AIDS hepatitis C bird flu swine flu covid-19 နဲ့တခြားသောဆေးတွေကိုဆက်လက်ပြီးတော့ထုတ်လုပ်ပေးနိုင်ဖို့ရအတွက်လည်းဆက်လက်ရှာဖွေလျက်ရှိပါတယ်ရှင်ARV therapy တွေအပြင် HIV AIDS တွေအပြင်ပေါ့နော် hepatitis treatment တွေမှာလည်းဒီ first ပေါ့ introduce လုပ်တဲ့ထဲမှာကုမ္ပဏီတစ်ခုအနေနဲ့ပါဝင်ဖြစ်ပါရဲ့ရှင်နိုင်ငံပေါင်း120ကျော်အထိပေါ့နော် product ပေါင်း2000ကျော်အထိကို registration လုပ်ပြီးရဖြည့်ပေးနိုင်ခဲ့ပါတယ်ရှင်ဒါကတော့ကမ္ဘာအဆင့်မီ R&D Center 6ခုကနေပြီးတော့ HIV AIDS oncology product တွေကို one lead molecule တွေအစီရှာဖွေတွေ့ရှိခဲ့ပြီးတော့ neurology diabetes cardiovascular disease hepatitis ophthalmology hematology နဲ့ autoimmune disorder တွေကိုလည်းဒီအပြင်က external partnership တွေနဲ့၎င်း in-house expertise တွေနဲ့ပေါင်းပြီးတဲ့ခါကျတော့ဆက်လက်ပြီးတော့ therapeutic တွေကိုဖော်ဆောင်ပေးနိုင်ဖို့အတွက်လည်းကြိုးစားလျက်ရှိပါတယ်ရှင်။ အခုပါဆိုရင်ပေါ့နော် diabetes အပြင်ပေါ့ကျွန်တော်တို့ဒီ CRN risk တွေကလည်းအရန်ကိုပြင်းထန်လာတဲ့အတွက်ဒီ HbA1c result တင်မကဘဲနဲ့ organ တွေကိုလည်းလက်ရှိမှာပေါ့နော် target ထားပြီးတော့ protection လုပ်နေရအောင်လည်းဆရာကြီးကိုပြောသွားခဲ့ပါရဲ့နော်အဲ့တော့ဒါညီမတို့စီ Empagliflozin အလေးကတော့ဒီ Empagliflozin နဲ့ Linagliptin combination ပေါ့ 10mg 5mg အပေါင်းလေးဖြစ်ပါရဲ့ရှင်ပထမအောင်ဆုံး US FDA အတွေ့အထားတဲ့ SGLT2 နဲ့ DPP4 fixed dose combination လေးဖြစ်ပါရဲ့ရှင်သူရဲ့ benefit တွေကတော့ဆရာကြီးတွေပြောသွားတဲ့အချိန်မှာပါတဲ့အတွက်ညီမ skip လိုက်ပါမယ်နော်ဒါတော့ဆရာကြီးပြောသွားတဲ့အတိုင်းပဲညီမတို့ဒါ cardiovascular အကြောင်းဖြစ်တဲ့ death တွေ hospitalization risk တွေကိုလည်းချောချပေးတာကိုတွေ့ရပါတယ်ဟုတ်ဒါလေးကကြတော့ Empa kidney trial ရအဆိုရင်ဒီ Empagliflozin ကိုစပြီး early initiation လုပ်မယ်ဆိုရင်ဒီ kidney hemodialysis လုပ်တဲ့ပေါ့နော်နှစ်တွေကို delay ဖြစ်နိုင်တယ်ဆိုတာကို result လေးနဲ့တွက်ထားပေးရဖြစ်ပါတယ်ရှင် eGFR 85မှာစပြီးပေးမယ်ဆိုရင်26နှစ်အထိ delay ဖြစ်နိုင်ပြီးတဲ့အခါကျတော့ eGFR 30မှာဆိုရင် 8.9 GR အထိပေါ့နော်ဒီ hemodialysis ကို delay ဖြစ်နိုင်တယ်ဆိုတာကိုလည်း result တွေအရာတွေ့ရှိရပါတယ်ရှင် kidney ဒီ impairment patient တွေမှာဆိုရင်တို့ adjustment လုပ်စရာမလိုဘူးဆိုတာကိုလည်းဆရာကြီးအရှိမှရှင်းပြပေးခဲ့ပါရှင်ကျမတို့ရဲ့ Amazon app 10.5 combination ကိုဆရာတို့ဒီ organ protection kit လေးတွေမှာအသုံးပြုပေးနိုင်ပါ recommend လုပ်ပါရရှင်ကျမတို့ဆေးလေးရောပါတက်ကို1300ကျပ်ပဲရှိပါရရှင်ဟုတ်နောက်ထောင်ပေးရဲ့အတွက်ကျေးဇူးအများကြီးတင်ရှိပါရရှင်တာယာတော်နေ့လက်ကလေးဖြစ်ပါသေးရှင်
Thank you for the presentation. Now we will proceed to the interactive question and answer session on optimizing organ production and glycemic control in everyday clinical setting. So may I invite all the chairpersons and speakers to join the discussion session to the stage. Dear participants, if you have any question, please feel free to raise your hand.
Thank you to the both speakers. Now the floor is open for questions. Any question from the audience? Prof. Sasawi. Would like to start from the, yeah, we have. Start from the in person, like this. Professor Sasawi.
Thank you very much for very excellent talk of the Baruah speaker. I would like to ask to Dr. Manash about the SGLT2. What about the role of SGLT2 in non-diabetic CKD, especially in the patient with high risk for UTI, like the renal stone or large PPH? Thank you.
Thank you. Good question, ma'am. Firstly, the first part. What is the role of SGLT2 in non-diabetic CKD? The data has evolved that they are fabulous drugs for non-diabetic CKD also. So actually the benefit of SGLT2 inhibitors are beyond glycemic control. Even without glycemic control, type 2 diabetic patient or non-type 2 diabetic patients will get the renal benefit. Because the whole mechanism is not only about, bringing down blood sugar. It's about combating the tubulo-interstitial glomerular damage. So firstly, SGLT2 inhibitors. One thing we must remember, SGLT2 inhibitors work firstly on the normal nephrons which are hyperfiltrated for whatever reason, the stage 1 CKD. And it decreases the hyperfiltration stage where There is more blood coming to the glomerulus all the time. And from that point onwards, it protects the kidneys. And otherwise, when they inhibit SGLT2 receptors in the proximal tubule, they not only excrete glucose, but also excrete sodium. When the sodium is excreted along with the sugar and goes to the distal tubule near the collecting duct, the sodium is sensed by the macula densa of the juxtaglomerular apparatus. That's near the collecting duct. And if the macula densa senses the presence of more sodium in that urine coming to that point, it will actually decrease the afferent arteriolar dilatation, making it constricted, afferent arteriolar, which is bringing in blood to the glomerulus. And if you get less blood in the glomerulus, the injury is less. That's how they protect their kidneys. So it is the natriuresis part, which is enhanced by SGLT2 inhibitors, which becomes protective to the glomerulus in the long run. It's not the sugar part. So that's why all the time, your kidneys are benefited, even in non-diabetic patient. That is a part one. There are other mechanisms. I'm not going to discuss about that. Number two, your question is about renal stone disease and UTI. UTI, I have mentioned. Upper urinary UTI, you should not use, especially pyelonephritis, acute or chronic. And if the chronic pyelonephritis happened long back and entire kidney has scarred, there is no active kidney tissue there, you may use. But otherwise, it is a contraindication. I think Professor Koko is also going to agree with me. Regarding lower urinary tract infection, in few weeks or few months' time, you should not use. You try to cure that cause. Prostatic hyperplasia can be cured either by TURP surgery or by giving medication which will bring down the prostate. When the flow improves, you do an ultrasound, there is no residual urine. The flow is good, then you can use. And you should also do a urine culture to see if there is no inhabiting bacteria inside the urine and all. So that's a relative contraindication which can be overcome in the future. Third thing about the stones, normal stones, there is no contraindication. But if the stone is obstructive and there is proximal dilatation of the ureter, you be very careful because that is a sit bed for future infection. You should get it released by the urologist, then only start.
Any more questions? Yeah. So I would like to, from the online, some questions we have. The question is 69-year-old lady, diabetes mellitus for 25 years. Currently, HbA1c 6.5 with Linagliptin alone. CKD stage 3A, controlled hypertension. Should I add low-dose EMPA to that patient?
A very interesting and tricky question because patient is already doing good on Linagliptin. HbA1c 6.5, what else you need? And control hypertension, yes. But I would put this person at high risk because the patient is already stage 3A, which is less than 60. And we know...
It doesn't mention about any proteinuria.
Patient has proteinuria. It has mentioned?
No, not mentioned.
Not mentioned. See, the benefit of empagliflozin in two parts. One is proteinuria reduction irrespective of baseline protein secretion in urine. That has been proven in EMPA kidney studies. So they did subgroup analysis. You started with normal protein excretion. You started with microalbuminuria. You started with macroproteinuria. All these groups got benefit in terms of future reduction in proteinuria as well as future prevention of GFR decline, which happens naturally to type 2 diabetic patient, as well as cardiovascular benefit. So at any stage, the benefit will come. So looking at this, if I am apprehensive about using two molecules, I think I will switch over to empagliflozin because already 3A. Otherwise, I have no problem in adding empagliflozin. But of course, this is a clinical question, and I would like to have Dr. Koko's opinion regarding this.
Well, I do agree because as in 2026 approaches the organ protection, she had a CKD stage 3A. It might be progression, even though, he's in very good condition at the moment because of diabetes control and then still hypertension is control, but still have a risk for the CKD 3A. So you should replace the Linagliptin with the Empagliflozin. If not control, if you go for combination of Empa and Lina, I do agree.
Yes.
So I just thinking why don't you combine pill, Empa and Lina in a half dose?
The question is
Because it's already
half dose.
of Lina and Empa, the same pill, in half dose, half a day.
Right.
Small.
Oh.
Can we do that?
Okay.
To get involved both.
See, this is off level. All drugs
Off label.
to get a benefit, we should use the prescribed dose. So 10 milligram is the lowest dose of empagliflozin. But when Glycemic came to, this is off level, my personal experience. When Glycemic came to Indian market, it was almost $1, which is very costly for many of our patients, even $1. So what we used to do, we used to take 25/5 Glycemic tablet and make it into 2 halves, so that at least 12.5 Empa the patient will get, because we are not worried about Linagliptin 2.5, because in India, we have got Linagliptin 2.5 also, once a day. We have got that preparation. But we must maintain at least 10 mg of empagliflozin. So I heard that their price is going to be very economical. I don't think there is any point to break it. Unless, of course, the patient cannot even afford that much. But the original innovator BI products are very costly. So we had to do it earlier. But nowadays we are not doing, because now it is 1/5 of or 1/4 of that price in India, similar to Myanmar.
So we have another question from Dr. Min So Woo. He asked, does the combination pill of empagliflozin and linagliptin have any effect on the development of neuropathy and retinopathy in patients with type 2 diabetes?
At least I cannot recall any strong clinical trial data on neuropathy. Retinopathy, of course, it's a similar microvascular disease as nephropathy. The one thing which is different from GLP-1 and empagliflozin is that both are good for the kidneys and the heart. GLP-1 is pharmacological dosing, so it is more potent. But many things are similar. Good for the heart, good for the, have PEF, good for the atherosclerotic vascular disease, and good for albuminuria and GFR protection of GFR. Now, there is one fundamental difference. GLP-1, they are still being tried regarding the risk of retinopathy progression. In fact, drugs like dual agonist tirzepatide, that's in level contraindication. If you have active retinopathy, do not use. And semaglutide has got neon, the so-called, a problem in the eyes, and we do not like to use them if there is active retinopathy requiring intervention. There is no such data for SGLT2 inhibitors. So I would say that if it's not preventing the progression, it is not harmful. But mechanistically speaking, because glomerular inflammation and injury and retinal vascular inflammation and injury are of same pathological nature, pathophysiological nature, benefit in the long run will come to the retina also. I'm not very sure about neuropathy. I don't recall any data you may highlight on that.
Right. Thank you. So SGLT2 receptor is also in the retina, right? Retinal fluid. So that's why if by giving the SGLT2, the diabetic retinopathy become better. This is all the evidence are there, all the articles are there. And one of our doctorate from the UM1 also study, is there any good benefit of the SGL2 in the diabetic retinopathy? What she find out is good. So you can use it SGL2 inhibitor in the diabetic retinopathy. There's no harmful effect. And also, we don't see any peripheral neuropathy sign or side effect of the neurological complication of the SGL2 as well.
Hello ဟောဆရာကြီးဆရာတို့ဆေးရအရန်ကောင်းတော့လေကျွန်တော်စဉ်းစားမိတာပေါ့နော်ဆရာတို့ဒီ HbA1c level လည်းမြင်မြင်ကျတယ်ဆေးရလည်း1% နဲ့ပိုကျတယ်ဆိုတော့ဆရာတို့လူနာတွေထဲမှာပေါ့နော်အဲ့ဒီဆေးပေးလိုက်ပြီးတော့ peripheral neuropathy ဖြစ်လာတဲ့လူတွေရှိသလားဒါမှကျွန်တော်တို့ဆေးပေးလိုက်ရင် HbA1c မြင်မြင်ကျပြီးတော့ peripheral neuropathy ရနိုင်လားဒါမှမဟုတ်ရင်ကျွန်တော်တို့ peripheral neuropathy မရအောင်ကြိုပြီးကာကွယ်ထားလို့ရလား
I don't think so. I don't think there is peripheral neuropathy worsening.
Only thing is, because there's because of the you give the insulin in diabetic peripheral neuropathy. If you very quickly couldn't bring down the HbA1c, there might be insulinitis effect. So in case of insulin period, we peripheral neuropathy ပူဆိုးသွားတယ်ဆိုတဲ့ theory ရှိတယ်အဲ့ဒါ insulin ကြောင့် insulinitis ဖြစ်သွားလို့ပေါ့နော်ဒါကြောင့်မလို့သူကဒီ nerve တွေကတော့ adaptation လို့တယ်ဆရာ adaptation လို့တဲ့ကြောင့် diabetic peripheral neuropathy တွေမှာ rapid control လုပ်တဲ့အခါမှာ very too much control အရန်မြန်ကြတာတော့တော်တော်သိမကြိုက်ဘူးဒါပေမဲ့အဲ့လို study တွေအကုန်လုံးက insulin နဲ့ပဲတွေ့တာများတယ်တောက်ဆေးနဲ့အဲ့လောက်ကြီးမကြတောက်ဆေးကကျွန်တော်ကြားတယ်လို့ပြောပြီးမဲ့လေကျွန်တော်က insulin လောက်မကြောက်ဆရာ insulin လောက်တော့ quickly control မဖြစ်တဲ့အတွက်ကြောင့် usually အဲ့ဒါမျိုးတွေ့တာတွေကကျွန်တော်တို့က insulin ကိုပေးပြီးမြန်ကြသွားတဲ့လူတွေမှာပဲ insulinitis ဖြစ်လို့ကျွန်တော်တွေ့တာပါဆရာ tablet နဲ့တော့ကျွန်တော်တို့သိမတွေ့ရပါဘူးမလေး
So I agree but for the SGLT2 inhibitor there are some evidence before with the is it Canagliflozin or something the food problem yeah there are some research SGLT2 like Canagliflozin with the worsening of peripheral neuropathy and more amputation so it might be some reason of the worsening of neuropathy with the initiation of SGLT2 in the patients with peripheral vascular disease as well as volume depletion, which can cause worsening of the foot problem. That is some evidence. Yeah.
Yeah, actually, when Canagliflozin appeared in the market 2012-13, two issues were the Frone's gangrene of the penile stump and foot ulcers were two issues, the critical issues, and there were black box warning for Canagliflozin because those were the initial years of this group of drug. And in the study itself, it has been criticized that what kind of people selection you had. You had probably advanced neuropathy patients also. But subsequent studies with dapagliflozin and empagliflozin has never shown this kind of warning, and that warning has been removed from all other SGLT2 inhibitors, and they are found to be safe for patients with peripheral vascular disease. In the long run, probably they are going to get benefit because we know that they benefit the vascular endothelium also. That's how they prevent the future atherosclerotic vascular disease. Of course, if the patient is dehydrated and there is severe occlusion of the peripheral vessels, a sudden dehydration may precipitate a gangrene. That's an individual case. But as a class of drug, for normal patients, they are not going to bring in new patients of diabetic foot ulcer. And Frone's gangrene has not been reported even with millions of patients of use, years of use has not been reported. And that's my take. I don't think these two issues are not contraindications now.
ဟုတ်ပါတယ်ဆရာအဲ့ SGLT2 ကကျွန်တော်တို့ Linagliptin campus study ဆိုတာလုပ်တယ်ဆရာအဲ့ campus study မှာသူက placebo ရဲ့ဆိုင်တော့ကျွန်တော်တို့က Lina ပေးတဲ့လူတွေမှာပို့ပြီးတော့ store amputation လေးရတယ်ဆရာဒါပေမဲ့သူတို့ကပြန်ကြည့်လိုက်တော့အဲ့ study ထဲမှာပါလူတော်တော်များများဒီလေ severe peripheral vascular disease ရှိတဲ့လူတွေပါနေတယ်ဒါကြောင့်မလို့ငကိုရဲအခန့်ရှိလို့ဖြစ်တယ်လို့သူကယူဆတယ် later တော့မှကျွန်တော်တို့ study တွေထပ်ထွက်လာတယ်ထပ်တဲ့အခါမှာမရှိဘူးမဖြစ်တော့ဘူးလို့ပြောပါတယ် peripheral neuropathy တော့မဆိုးသေးဘူးဆရာဒါသိကြတယ်ကျွန်တော်တို့ကပိုတော်ကောင်းတယ်ဆိုတာရှိတယ်ဆရာတို့ internet မှာရိုက်ထည့်လိုက်ရင်လည်းနော် can SGLT2 worsen the peripheral neuropathy no word ထွက်မှာဆရာမရှိပါဘူး protect လုပ်ပါ
Hello. Thank you to the Manash and the Professor Koko for your informative talk. We learned a lot from your presentation. My first question goes to Dr. Manash. We already know that SGLT2 usage is causing UTI in some cases, but adding Linagliptin to the Empagliflozin that you mentioned on the slides, UTI risk is lower than SGLT alone. Or could you explain about the detailed mechanism of this combination can reduce the UTI? The first one.
You're talking about GTI, right?
Yes, GTI.
GTI, yeah, genital infection. Yeah, this is not only for Empalina. This is also for Dapasita. And there was another drug called Remogliflozin. I don't know whether it is here or not. In India, we have Remogliflozin plus sitagliptin combination or vildagliptin combination. And their data also shows the same thing. So it is a kind of a class effect where SGLT2 plus DPP4 inhibitors bring down the GTI. The explanation in single line I had mentioned. Actually, DPP4 inhibitor, the gene for DPP4 inhibitor is very old. You will be surprised to know that single cell organisms, when they transitioned into eukaryotes and megakaryotes, that phase itself means multi-cell complex organism from single cell. That point itself, they acquired the DPP4 inhibitor, DPP4 gene. That means those organisms also have DPP4 genes. During COVID, you must have read a lot of papers saying that DPP4 can be pathognomic for COVID because DPP4 is found in various fungi, bacteria, and viri, where they help these organisms to attack your body and overcome the body's immune system. So if you inhibit DPP4 in those organisms, you are preventing that pathognomic pathway. And that's why GTI is caused by fungi. And if you inhibit that pathway, less GTI will happen. So GTI, SGLT2, DPP4 inhibitor blocking the pathway, so there will be less incidence. So far, this is the only explanation to my knowledge. Otherwise, it is a open science. More things are going to come, but you have to believe it to some extent at least. All the combinations, not only this, all of them have shown that protection. And the only explanation that they are expressing DPP4 and you are inhibiting that expression, so they are less pathognomic. They are less pathological.
Okay. Next question is, please, I have next questions. You mentioned fixed-dose combination with immediate metformin and their long-term linagliptin is not got, you mentioned. So in Myanmar, immediate release metformin 500 milligram with linagliptin half dose 2.5 milligrams available with so many brands. It is rational or not? Please answer.
It is not exactly rational. If you aim linagliptin to be a single pill once a day, it is not rational. But on the other hand, linagliptin given twice a day retains its metabolic efficacy as good as once a day. So just to help metformin, you are making it twice a day. That's a compromise, but your metabolic efficacy is not going to go down. It will remain the same. So for individual patients, that is justified. That is justified. But luckily now in India, we have got linagliptin 5 mg with sustained release metformin, and that has actually beaten the other preparation to the second place. We are using 5 mg Linagliptin with sustained release metformin once a day only. And people like once a day pill. That's why you use Linagliptin. I think so that very important. So it is better to have a sustained release metformin along with Linagliptin. I think it will come. In India, it is widely popular now. Thank you.
Okay, thank you for the time constraint. Just one question from the line. Asking the Empagliflozin 10 milligram, can it be broken to half tablet? Is it still effective for organ protection or not?
I have already answered that question. For organ protection, minimum dose used was 10 milligram. I think we should not do that.
So thank you. So because now time is up for the closing time. So I would like to put the closing remarks and winding up. Distinguished guest speakers, ladies and gentlemen, today's symposium has highlighted the complementary strengths of two important agents in modern diabetes management, Linagliptin and Empagliflozin. After metformin, these two are the most appropriate for majority of type 2 diabetes in our country as well. Linagliptin as a DPP4 inhibitor offer moderately effective glucose control with a low risk of hypoglycemia, with neutrality, and a unique advantage of requiring no dose adjustment in patients with renal impairment. It remains a practical and safe option across a broad spectrum of patients with type 2 diabetes, including elderly. Empagliflozin, an SGLT2 inhibitor, extends benefits beyond glycemic control. It promotes weight reduction, lower blood pressure, most importantly, provide proven cardiovascular and renal protection, helping us address the broader metabolic organ-related complications of diabetes. As we don't want to miss the benefits of SGLT2 inhibitors, they have to be initiated earlier according to the current guidelines. When these two agents are combined into a single tablet, the benefits become even greater. Through a complementary mechanism of actions, the combination delivers enhanced glycemic control while maintaining the low risk of hypoglycemia. At the same time, patients can enjoy the cardiorenal benefits and empagliflozin together with the renal-friendly profile of linagliptin, providing 360-degree benefits. Equally important is the convenience of the single pill combination, which reduces pill burden, simplifies the treatment regimens, and may improve medication adherence, an essential factor for achieving long-term treatment success. So as we come to the end of today's symposium, one pill, double impact, I would like to express my heartfelt thanks to our distinguished speakers, guest speaker, particularly Dr. Manash, who has come all a long way from India and sharing his expertise. Thank you very much. We also like to thank all the participants for your attention and commitment to improving the lives of people living with diabetes. Finally, I'd like to thank to the Hetero Pharmaceutical Company for supporting this educational event and the launch of this promising combination therapy, Empazox L. Thank you very much. Thank you.
Thank you. We would like to express our heartfelt appreciation to our respected chairperson and honorable speaker for sharing their valuable knowledge and time with us today. So may I invite Mr. Babesh Bakila to give an appreciation gift to our honorable moderators and panelists. May I invite our chairperson, Professor Tantan A, to receive our appreciation gift from Hetero. Thank you, Professor, for accepting the gift. Then, may I invite Dr. Manash to receive the appreciation gift from Hetero. Lastly, may I invite Professor Kuko to accept the appreciation gift from Hetero.